Hello.
Sorry, I was making some tests. Hello. David, te pongo a ti de entrada de intérprete de inglés hasta que hablen los dos primeros miembros institucionales y luego te cambio a francés.
Buenos días, Naira.
Buenos días, David. Como los dos primeros participantes van a ser institucionales y van a hablar en español, ¿te importa? Tú haces la interpretación en inglés a esas dos personas que van a dar la bienvenida y luego ya te paso a francés.
Vale,
Vale,
perfecto.
perfecto. Te asigno a inglés entonces.
Vale.
Hola, Naira.
Hola, buenos días, Asma.
¿Qué tal? Hola David y Orián.
Buenos días, Asma, ¿cómo estás?
Bien, bien.
Me alegro.
Hola, buenos días.
Buenos días. Mire, quería comentarle, no sé si se los comentó Naira, vamos a tener una persona que va a hablar en español. No sé si una o dos al principio de la sesión, entonces no sé si es posible cuando hable en español hacer las traducciones al francés y al inglés. Es
Sí, ya
simplemente para
asigné yo a
inaugurar.
Paul,
¿Sí?
perdón, a David al
Sí.
inglés y Orián hace la de
Ah,
francés.
vale, perfecto. Pues nada, y muchas gracias, así por la sesión de hoy y por todo el esfuerzo durante lo que duró el curso.
A ustedes, muchas gracias.
Sí, y si hablan con Nolwyn, pues nada, que fue todo, que ya se lo explicaré en otro momento con tranquilidad. Lo de la
Vale,
factura que fue por el cierre contable y todo rollo que hubo.
vale, perfecto, no te preocupes. Gracias,
Bueno, de
gracias,
nada.
Asma, gracias.
Bonjour, professeur Yahya.
Bonjour, comment vas-tu?
Très bien, et vous? Ça va?
Ça va très bien. J'étais un peu en voyage, je viens d'arriver hier soir.
Oui.
Là où j'étais, la connexion c'était très faible, j'ai
Sí,
pas pu
hola,
assister. Hola,
D'accord.
Hola, buenos días.
buenos
Almudena.
días,
buenos
buenos
días.
días. ¿Qué tal?
Bien, aquí probando la conexión.
¿Se me oye bien, no? ¿Se ve bien?
Sí, sin
Sí,
problema.
sí,
Vale,
perfecto.
muy bien, gracias.
De nada. Bonjour, professeur Ali Sili. Heureux de vous avoir avec nous dans l'événement d'aujourd'hui. Je ne sais pas si vous avez eu le temps de connaître un petit peu plus le projet, mais on aura certainement le temps de parler, de vous passer toute l'information sur ce qu'on a fait avec tous nos partenaires, mais surtout avec nos collègues de la faculté de médecine en Mauritanie. On ne vous entend pas parce que vous avez le micro désactivé.
Bonjour
Oui.
tout le monde.
Bonjour.
Donc, c'est un honneur pour moi d'assister avec vous à cette journée dédiée à la technologie médicale au service du développement durable en Afrique.
Merci
Et
beaucoup.
voilà, donc je crois qu'au courant des débats, j'aurai plus d'informations, plus de trucs qu'on va échanger ensemble.
Oui.
En tout cas, c'est tout un honneur. Et mon ministre aurait voulu bien assister à cette journée.
Oui.
Mais pour des raisons de calendrier, il n'a pas eu le temps de participer.
Oui.
5 minutes.
Voilà.
En tout cas, merci beaucoup pour avoir accepté notre invitation. Et nous étions en contact avec le ministère d'éducation supérieure et on est content d'avoir aujourd'hui avec nous les représentants du ministère d'éducation et de la réforme. Ainsi que, merci beaucoup.
Merci, merci.
Hi Ron, hi Simon.
Hi Asma, welcome back.
Thank you.
Naira,
¿Sí?
cuando puedas nos vuelve a meter intérprete porque no estamos en cabina.
Vale, un segundo.
Gracias.
Qué raro que se haya caído en la cabina.
Hola, buenos días.
Buenos días, Nasara.
Bonjour. Hola, Almudena.
Hola.
Bonjour.
Enchantée, Alicili. Sumer, je suppose que vous êtes de la Mauritanie, le ministère de l'Éducation. Soyez la bienvenue.
Votre micro est désactivé, Monsieur Ali.
Ah oui, je l'active. Oui. Merci beaucoup de cette invitation. C'est tout un honneur pour nous d'assister à cette journée.
Merci à vous de participer. C'est un plaisir pour nous.
Merci.
Merci beaucoup. Hola, Almudena, ¿qué tal?
Buenas, ¿qué tal? Bien. Finalizó ahora la comisión de la consejera y ya justo medio tiempo de conectarme.
Qué bien, porque yo también vengo ahí de reuniones que se han alargado, pero bueno, ya estamos aquí. ¿Qué tal, Asma? ¿Estás por ahí también?
Hola, Nazara. Sí que estoy aquí.
Muy bien. Que voy a preparar esto para después cuando me toque a mí compartir pantalla,
Sí.
que creo que nunca he compartido pantalla, siempre utilizo el Zoom, pero no. Ah, bueno, pero abajo lo tengo, compartir pantalla, sí. Estupendo. Vale, lo voy a dejar preparado. Y bueno, todavía quedan 10 minutitos, ¿no?
Sí, sí.
¿Cuánto tiempo? ¿Qué tal? Y tú eres Naira, ¿no?
Sí, yo soy Naira.
Encantada, Naira, que no nos habíamos visto.
Sí, estoy aquí en la esquinita.
Hola, Alessandra.
Olá, Rasma, tudo bem?
¿Todo bien? ¿Y tú?
Também.
Hola, Alexandra.
Olá, Naira, tudo bem?
Todo bien. Qué bueno volver a verte.
Obrigada, o mesmo para ti.
Buenas tardes.
Buenas tardes, Carlos.
Hola, buenas tardes.
Hola.
Buenas tardes, Juan.
Buenas tardes, Juan, también. ¿Qué tal, Carlos?
il est 13 heures.
Bueno, comenzamos entonces. Bienvenidos y bienvenidas. Soyez tous et toutes la bienvenue. Welcome everybody. Je suis Nassara Cabrera-Au, directrice générale des affaires économiques avec l'Afrique du gouvernement des îles Canaries. Soyez tous encore et toutes la bienvenue à cette journée du projet formation des formateurs. C'est un grand plaisir pour le gouvernement des Canaries, en tant qu'organisateur de cet événement, de vous avoir parmi nous aujourd'hui. Et je vous remercie beaucoup de vous joindre à nous. Avant de commencer, je voudrais remercier aussi l'équipe technique pour le travail qu'elle a accompli et je remercie publiquement l'Institut technologique des Canaries pour son travail, en particulier Alma Cruz, Naira Pumar et Asma Scaret, ainsi que Juan Alsola de la part de l'Université de Las Palmas de Gran Canaria. Je suppose que vous serez déjà très habitués à la plateforme de Zoom à ce moment de la pandémie, mais vous pouvez trouver une icône en forme de ballon ci-dessous où vous pouvez accéder à l'interprétation simultanée dans la langue de votre choix. Si vous avez des problèmes, vous avez aussi l'assistance technique de Naira Pumar pour vous aider. Sans plus tarder, je laisse place à la séance d'ouverture de cet événement et je passe la parole au vice-ministre régional de l'économie et l'internationalisation du gouvernement des îles Canaries, Madame Almudena Esteves. Adelante, Almudena, cuando quieras. Buenas tardes y muchas gracias.
Hola, bueno, muchísimas gracias por la invitación a esta jornada de formación de formadores. Muy buenos días a algunos y buenas tardes a otros y a otras, ¿no? Por los cambios de los usos horarios. Es un placer y un honor para mí pues darles la bienvenida a esta última jornada internacional de formación de formadores en este año 2020 que espero que continúe. En primer lugar, pues un poco agradecer a todos los participantes, disculpar también a la consejera Elena Mañez que bueno, le hubiese gustado estar aquí pues inaugurando esta última jornada y por motivos de agenda no ha podido estar, ¿no? y también darle las gracias a Sara Cabrera, la directora general de Asuntos Económicos con África, porque pues organizar estos seminarios, ¿no?, junto con los demás organizadores, pues es importante porque creemos que el conocimiento y la formación es clave, y más en estos momentos de situación de recuperación económica, ¿no? Esta jornada que aúna el Gobierno de Canarias con centros de reconocido prestigio, universidades de Estados Unidos, Canadá, países africanos y europeos, así como la Embajada de Senegal en España y directores del Ministerio de Educación de Mauritania. Un gran saludo a todos y a todas y muchas gracias por su participación, donde se hablará tanto de los resultados obtenidos en el proyecto de formación de formadores en tecnología médica, que creemos que es de vital relevancia ahora, tecnología médica, vigilancia epidemiológica, uso y gestión del agua, como de los avances experimentados también en tecnología médica y la transparencia de conocimiento de esta a otros países y su aplicabilidad en ellos, ¿no? En todo esto, desde el Gobierno de Canarias, estamos convencidos de que Canarias ha jugado y juega ahora mismo y puede jugar un papel clave en todo ello como nodo internacional donde confluyen y desde donde se impulsan proyectos que unen a profesionales, a expertos y expertas de todo el mundo. Tenemos que tener clave, y eso es un tema que siempre queremos exponer a los demás centros, que nuestra posición geoestratégica hace del archipiélago un enclave ideal para realizar esa transferencia de conocimiento desde diversas partes del mundo y dirigida hacia países africanos especialmente, que son nuestros vecinos naturales, ¿no? Y donde tenemos bastantes lazos estrechos. Por otro lado, también es verdad que además somos el único gobierno autonómico del Estado que tiene un centro directivo que está únicamente dedicado a las relaciones con los países africanos. O sea, la Dirección General de Asuntos Económicos con África realmente es esa función, y creo que no hay más centros directivos en todo el Estado, cuya tarea también es alinear a las entidades canarias y facilitar sus relaciones con las entidades africanas de cara a crear colaboraciones futuras, ¿no?, beneficiosas para ambas partes, y que se establezcan en base a la relación recíproca, donde cada parte pueda aportar lo mejor de sí misma. Ese interés que acabo de mencionar en establecer más y mejores relaciones tiene ya un recorrido, ¿no? Es un hecho que África conforma nuestro segundo destino de exportaciones, de modo que también contamos con más de 200 empresas instaladas en esos países, en el África Occidental. De la misma manera, en el ámbito normativo, y en concreto en nuestro estatuto de autonomía, África ocupa un lugar destacado. También es verdad que en nuestro régimen económico y fiscal, la internacionalización de la economía canaria en el artículo 18 tiene un lugar bastante destacado, y aparte específicamente hay un artículo 72 bis de esta ley donde se regula la deducción por inversiones en territorios de África Occidental y por gastos de publicidad y propaganda. Hay que mencionar aquí también nuestra zona SEC, ¿no?, que tributa al 4%, tenemos incentivos fiscales que estamos intentando dar a conocer más aún su difusión, y es el más bajo de Europa, y también es un atractivo, ¿no?, para que empresas de diferentes ámbitos y de conocimiento, por supuesto, se instalen aquí. Además, contamos con una red exterior. Canarias tiene, como si dijéramos, unos embajadores, ¿no?, en países vecinos con los que se crean históricamente lazos. Estamos en Mauritania, en Senegal, en Cabo Verde y en Marruecos, y bueno, son nuestra cara visible allí. En definitiva, se están llevando también acciones con África. Cabe destacar en este caso la concesión de becas de jóvenes de nuestros países vecinos, para que jóvenes de nuestros países vecinos vengan a estudiar a Canarias, y el proyecto Sagón, que también es un proyecto de carácter estratégico del Programa de Cooperación Territorial Europeo Territorial MAC 2014-2020, y está financiado un 85% por el FEDER y dirigido a apoyar el programa de la Autoridad de Gestión de Dinamización de la Cooperación con Cabo Verde, Senegal y Mauritania. y en promover la concertación de fondos FED-FEDER de acuerdo a las directrices de la Comisión Europea. También tenemos que destacar lo que hablábamos antes, la posición estratégica, la conectividad aérea, o sea, Canarias dispone de 8 aeropuertos, 6 de ellos internacionales y además de muchísimos vuelos directos a través de países europeos, entre los que destacan Reino Unido y Alemania, y tenemos vuelos directos semanales. Y bueno, ya para ir terminando, también albergamos el Centro Logístico de Ayuda Humanitaria de Cruz Roja y Media Luna Roja en el Puerto de la Luz de Las Palmas, uno de los 5 centros logísticos del Programa Mundial de Alimentos de Naciones Unidas. Por todo ello, además de la experiencia de internacionalización de nuestros centros de investigación y de desarrollo tecnológico, la economía azul, las energías renovables y la transferencia de conocimiento se convierten en vías potentes de internacionalización que además pueden potenciar de manera muy importante el desarrollo de los países africanos, al mismo tiempo que el nuestro propio, ¿no? Yo creo que se crean sinergias con la transferencia de conocimiento entre los países africanos y Canarias, y creo que, bueno, esta tiene que ser una de las muchas ediciones, porque esto tiene que tener continuidad, ¿no? África está ahí, somos, como decíamos, nuestro vecino natural y con los que tenemos bastantes lazos y relaciones comerciales. Muchas gracias y espero que disfruten de la jornada.
Muchas gracias, Almudena. Par la suite, je passe la parole à Monsieur Carlos Navarro, directeur de l'Agence canarienne pour la recherche, l'innovation y la société de la información. Carlos, adelante, muchísimas gracias por estar aquí. El audio, Carlos.
Decía que muchas gracias, compañeras, y nada, bonjour, good afternoon, buenas tardes a todos y a todas. Y simplemente no quiero repetirme mucho más con las palabras que ya se han dicho, simplemente decir que la idea de vincular la I+D, la innovación para África, las posibilidades que puede ofrecer Canarias y la política europea al respecto y a otros lugares del mundo me parece una iniciativa maravillosa. Canarias tiene un gran potencial en tecnología médica y establecer sinergias con nuestro continente vecino y Europa la fortalece como nodo internacional y la sitúa de forma estratégica. En el momento actual, actuaciones como las de hoy son de vital importancia para avanzar en el sector sanitario y obtener una mayor excelencia y competitividad frente a los retos presentes y futuros. Desde Canarias y especialmente desde la agencia que dirijo, desde la CICI, como organismo del Gobierno de Canarias que lidera la I+D+I, quisiera felicitar a los organizadores de esta jornada, al equipo de profesionales y expertos que están en el proyecto, así como a todos los ponentes y participantes. Proteger la ciencia y la innovación es proteger la vida. Muchísimas gracias.
Muchísimas gracias, Carlos, por estar aquí con nosotras y también por tus palabras. Donc, c'est à moi et maintenant je vais présenter brièvement une introduction au projet de formation des formateurs. Je vais partager l'écran. Est-ce que ça marche?
Oui.
D'accord.
Yes.
Donc, je vais présenter brièvement seulement, je vais faire une introduction.
I'm going to...
C'est bien? Vous voyez? D'accord. Le programme international de formation des formateurs a regroupé plus de 300 professionnels et experts de 15 différents pays qui ont travaillé en étroite collaboration pour mettre en place un programme de formation en matière de santé, surveillance épidémiologique et traitement des eaux. Les institutions canariennes ont joué un rôle protagoniste en mettant les moyens humains et financiers pour la création d'un réseau durable de connaissances, des partenariats stratégiques et solides entre toutes les institutions nationales et internationales qui participent à cette initiative. Spécifiquement, le nombre de participants bénéficiaires des formations sont 340 Et nous avons eu une quinzaine de pays participants tels que le Sénégal, la Mauritanie, le Cap-Vert, le Maroc, le Ghana, le Mozambique, le Soudan, le Bénin, la Côte d'Ivoire, le Congo, l'Espagne, le Canada, les États-Unis, la Roumanie, le Portugal. En outre, plus de 36 institutions de 3 continents ont été impliquées, c'est-à-dire l'Amérique du Nord, l'Afrique et l'Europe. Les programmes de formation, parmi les événements organisés, les programmes de formation se divisent en 4 principaux axes, comme on voit ici. L'anatomie digitale, il s'agit d'une formation qui a pour objectif de renforcer les capacités et compétences des professionnels de santé en matière de recherche de technologies de traitement d'imagerie médicale, comme vous bien savez, et recherche computationnelle. La formation s'est étalée sur plusieurs semaines entre janvier et décembre 2020. Ici, quelques exemples d'atlas anatomiques réalisés par nos partenaires africains au Sénégal et en Mauritanie. Les thérapies guidées par l'image, les participants à cette formation s'initieront aux différentes techniques et aux possibilités offertes par les systèmes IGT dans l'entraînement, mais aussi les planifications chirurgicales. La photo est prise lors d'une session de formation sur le système IGT à Nouakchott. En troisième lieu, la surveillance épidémiologique, les cours de vigilance épidémiologique est destiné aux étudiants et étudiantes en 6e et 7e année de médecine en Mauritanie et il a été réalisé par l'Institut universitaire des maladies tropicales et de la santé publique des îles Canaries et se fait en collaboration avec l'Organisation mondiale de la santé, de l'Agence espagnole de coopération internationale pour le développement, l'AECID, et le Bureau technique de coopération. Aussi l'ambassade espagnole à Nouakchott et la faculté de médecine de Nouakchott. Et pour finir, le traitement des eaux urbaines, qui c'est une formation élaborée par l'Institut technologique des îles Canaries avec une vaste expérience dans les énergies renouvelables et dans le dessalement et la réutilisation des eaux usées, entre autres sujets. L'objectif du cours est la formation sur l'usage des eaux résiduelles et la prévention des maladies. Elle est d'une cruciale importance, spécialement dans cette période de pandémie COVID-19. La formation est prévue du 23 novembre au 11 décembre et elle est destinée principalement aux ingénieurs industriels en Mauritanie et au Sénégal. Finalement, au-delà des excellents résultats pratiques de la formation offerte aux professionnels des pays participants, nous avons réussi ensemble à relever des grands défis et contribuer tous activement à la création d'un réseau de collaboration aussi bien institutionnel que scientifique que j'espère sera durable dans le temps. Nous sommes heureuses de savoir qu'un laboratoire d'anatomie digitale a été créé au niveau de l'université Cheikh Anta Diop et qu'un centre de thérapie guidée par l'image verra le jour bientôt au sein de l'enceinte de la faculté de médecine de Nouakchott. Nous remercions tous les experts qui ont fait possible la réalisation de ces projets. Nous comptons parmi nous des chercheurs de premier rang qui sont aujourd'hui co-auteurs de plusieurs articles scientifiques avec des chercheurs africains et canadiens. Nous savons aussi que certaines thématiques de cette formation, surtout celle d'anatomie digitale, font partie intégrante de la formation officielle d'anatomie dans certaines universités africaines, au Mozambique, Sénégal et Mauritanie. Il y a aussi plusieurs projets en cours qui ont vu le jour grâce à la synergie entre les différentes institutions participantes dans ces projets. Les îles Canaries aujourd'hui se positionnent comme acteur principal de la coopération tricontinentale reliant l'Afrique, l'Amérique et l'Europe. Merci beaucoup. Donc, nous allons donc maintenant passer à l'intervention je vais laisser de partager l'écran. Un moment, s'il vous plaît. Bon. Pardon. Ah, ici, ok. D'accord. Pardon. C'est déjà. Ok, je laisse de partager mon écran.
Oui.
D'accord, merci. Donc, je ne me suis trompée pas. nous passons ensuite maintenant à l'intervention de son Excellence, l'ambassadrice du Sénégal en Espagne, Madame Mariam Sy. Madame, vous êtes là?
Excusez-moi, Nassara, je viens de parler avec l'ambassade du Sénégal à Madrid. Madame l'ambassadrice a eu un empêchement, donc elle n'a pas pu se connecter à l'événement d'aujourd'hui.
D'accord, donc je suis désolée par l'ambassadrice. Donc, nous passons ensuite à l'intervention de le secrétaire général, M. Ali Sidi Soumar, et les conseillères du ministère de l'Éducation en Mauritanie, M. Ahmed Ba. Merci à vous tous les deux de participer et je vous cède la parole.
Merci beaucoup. Merci beaucoup. Bonsoir à tous. Monsieur le vice-premier ministre de l'économie et internationale du gouvernement des îles Canaries, monsieur le directeur de l'agence canadienne de recherche et innovation, madame la directrice, et c'est un honneur de participer avec vous et pour cette journée que vous avez dédiée, sachant que le bilan est éloquent, tout ce que vous avez réalisé. Et encore, merci encore pour ce que vous avez fait et pour l'Afrique et pour le monde entier, sachant que votre intervention est venue à point nommé, c'est la COVID-19 qui a bouleversé le monde entier, le fonctionnement du monde entier. Et donc, c'est un honneur pour nous d'assister à ce bilan que vous avez dressé tout à l'heure, sachant et avec des réalisations concrètes. Moi, je ne voulais pas m'attarder beaucoup sur ce qui est, parce que vous nous avez demandé d'intervenir sur l'éducation, santé, défis et enjeux. On sait que l'éducation et la santé sont nécessaires pour l'épanouissement de l'être humain, mais aussi pour le fonctionnement de sociétés, des différentes organisations. L'objectif principal de l'éducation est la transmission par un peuple de sa civilisation, d'une génération à l'autre. Elle peut contribuer à la réalisation des objectifs de développement durable et considérer ces faits un moyen d'améliorer de la santé et du bien-être des populations. La santé, comme on le sait, c'est vraiment perçu comme un état physique mental relativement exempt de gêne et de souffrance qui permet aux individus de fonctionner efficacement et aussi longtemps que possible. Alors, la mise en œuvre de la santé et de l'éducation pour assurer une bonne mise en œuvre, alors on doit mettre en place des politiques, des programmes et l'organisation des soins de santé. En Afrique, l'accent est mis au niveau santé sur le soin de santé. Par contre, les recherches en santé sont rares et nécessitent des financements, d'où votre intervention qui va alléger encore les souffrances de certains. Pour rendre la santé et les soins médicaux accessibles à tous et à toutes, il est essentiel. 3 enjeux pour la santé, pour le secteur de la santé en Afrique sont significatifs afin de permettre l'éclosion d'un secteur plus fort. Il s'agit en fait de 3 grandes pénuries de la santé en Afrique. Des financements suffisants, un personnel compétent en nombre suffisant, un support d'infrastructures adapté et équipé. Donc ça, c'est vraiment ce qu'on peut dire pour ce qui fait de la santé. Il faut des financements suffisants qui nous permettent d'acquérir les technologies qu'il faut, d'avoir un personnel compétent et adapté avec un support d'infrastructure adapté et équipé. Aussi, il y a lieu aussi pour réduire l'écart grandissant qui se développe entre les pays pauvres et les pays riches. Nous préconisons de promouvoir un pôle de développement et de partenariat pour atteindre les objectifs spécifiques de développement durable, appuyer financièrement les institutions de l'éducation et de la santé pour faire progresser la science et la technologie, la création de fonds spécifiques pour la rénovation, développer des technologies médicales fiables et abordables. pour pallier aussi à la pénurie en personnel de santé en favorisant la télémédecine, nous préconisons de renforcer la recherche scientifique et la formation des personnes ressources, ce que vous êtes en train de faire, proposer des solutions liées à la télémédecine qui compenseront en partie les manques dont souffre l'Afrique pour qu'elles permettent un accès aux soins aux populations les plus isolées tout en compensant la faible densité des médecins. La technologie comme substitut aux défaillances des systèmes de santé, là, nous préconisons d'utiliser les technologies comme des solutions originales, complémentaires, contrebalancer en partie les absences spécifiques au secteur de la santé, des matériels dans tous les hôpitaux et dispensaires, et les freins spécifiquement liés à la Mauritanie, difficultés de transport par la route. Encourager l'innovation et soutenir le développement de la technologie domestique. Donc, c'est tout un ensemble de propositions que nous avons ramassées ici et là afin de nous permettre d'échanger. Et je sais que les îles Canaries, c'est à 1h30 de vol de la Mauritanie. Et c'est vraiment un honneur de pouvoir échanger avec vous, partager nos différentes expériences, sachant qu'on sait que vous avez quand même des technologies qui peuvent vraiment alléger certaines souffrances. Et comme vous l'avez dit, comme l'a dit le vice-ministre tantôt, il faut développer l'échange. C'est un échange gagnant-gagnant. On peut trouver quelque chose aux îles Canaries qu'on ne trouve pas en Mauritanie et vice-versa. C'est en fonction de ça qu'on peut échanger et que chacun trouve sa part dans les différents échanges. Donc, je ne veux pas m'attarder beaucoup c'est vraiment un honneur de participer avec vous et je suivrai avec attention la suite des débats. Et si nécessaire, je pourrai intervenir à la fin. Je vous remercie beaucoup.
Merci beaucoup, monsieur. Je ne sais pas, je suppose que oui, le conseiller du ministère de l'Éducation en Mauritanie, il va intervenir.
Non, c'est juste un accompagnant.
D'accord. Donc, merci beaucoup de toute façon pour être ici. Donc, la dernière intervention de cette première partie sera faite par Madame Mafini Dosso, Project Leader de Smart Specialization in Innovative and Informal African Economies du Joint Recherche au Centre de la Commission européenne. Un plaisir, Madame Dosso. C'est un honneur de vous avoir ici. Et allez-y quand vous voulez. Madame Dosso est là?
Je pense qu'il a eu des problèmes de connexion.
Et il est reconnecté.
Voilà, c'est bon.
Il est là.
Merci. Bienvenue, madame. Allez-y.
So she was online a few minutes ago. So perhaps she's reconnecting.
Sorry, is it my turn? Hi.
Yes. Yes, this is your turn.
¿Me podéis oír? Hola.
Sí, sin problema, te oímos.
Bienvenida, Mafini.
Oh, ok, estupendo. Perdón, no sé qué ha pasado, pero me echaron de la reunión, perdón.
Vale,
Sorry.
No hay problema.
Okay, I just tried to share my screen. I don't activate the video because I'm not sure how the internet will react. So I will share first the screen.
Okay, don't worry. Go ahead. Yeah.
Okay, can you see the screen, full screen?
Yeah,
yes.
Okay, perfect. So I think I'm not on time. I'm sorry, I got a lot of connection problem. I'm in Abidjan, as I was telling to Rhys yesterday. So thank you very much for inviting me to speak a bit about the EU-Africa STI cooperation, and I think most importantly, which avenues we can find for further collaboration using Canaria, if I can use this expression, as a perfect geographical bridge between Europe and the continent. So I'm Afini Dosso. I'm leading a project on smart specialization with Africa at the European Commission Joint Research Center in Sevilla. I thought that the most important was to start by giving you some
Now we don't listen to you.
Probably the connection.
Yeah. Maybe she's having problems. Yeah. I suppose she's trying to enter again. Sorry for this problem. It's normal.
Sorry.
Don't
We try
worry.
again. I'm so sorry. I don't know what happened. Otherwise, can you see now?
Yes, yes, we can see.
Okay, so as our slide, what we call the milestone of the Africa-EU cooperation, let's say that the will to go beyond the donor-recipient dimension of the cooperation was, let's say, formalized through the joint Africa-EU strategy adopted in Lisbon in 2007. Then, as you can see further, we had a more structured approach to the policy-to-policy dialogue through the high-level policy dialogue. And this, of course, has given rise to multi-thematic partnerships. And some of them are very, let's say, relevant from the role Canaria Iceland want to play in between Africa and Europe. So since now 2019, we launched what we call the Africa-Europe Innovation Partnerships. Very briefly, clearly, the European Union and the African Union are undertaking some joint research and innovation activities, of course, to fight the human health impact of the COVID, but clearly much beyond the socio-economic impact that the pandemic is having on our societies. So the priorities, let's say, have been adjusted to the context, to the global pandemic context, and of course, to the issues of climate change and anything, let's say, related. So there's been targeted action under public health, of course, green transition, we see further in terms of innovation and technology and capacities for science. And I think that at least the last 2 points are very important for the meeting we're having, because it's also about training, but also training the trainers to ensure that we have a sustainable pathway for the development, to achieve the development goal. So specifically under the public health action, there's been the pledge for the coronavirus global response, which has allowed to mobilize more than 15 billion of euro. There's been also the initiative of the European and developing. The second, let's say, line of action, green transition. There's been the continuity of what we were already doing in terms of research and innovation cooperation, targeting improved nutrition and sustainable agricultural practices, and others targeting more the adoption of more sustainable energy practices or sustainable energy sources. And there's been some specific action, especially data-driven action to both offer some monitoring tool for the environment and security, but also some other specific F observation. We can go further now, but there's been also specific action. I think these are the 2 points where we are interested. They're both the innovation and technology, where we have been, as I was mentioning, launching the last year, the EU-AU innovation partnerships. And there's now the joint effort to design the roadmap to achieve these innovation partnerships. There's a strong focus, of course, and the COVID has put forward clearly was underlined the digital divide that was already existing, but let's say has amplified the digital divide. So maybe draw the attention toward more investment into the digital literacy or also the digital infrastructure. Then there've been, since this year, the project I think has now been approved in between relating the innovation hub from one side to the other side. I think more or less more than 20 memorandum of understanding have been signed already in between African countries and European countries hubs. And there's been dedicated action to support the access to publication, but also to fair research data, especially in this case related to SARS-CoV-2, and dedicated training and equipment for health workers under the European CBRN. So as I was mentioning, I'll talk about this with Dr. Juan yesterday, that we was on Europe, so the new multi-annual programming for the research and innovation at the level of Europe, planning about 100 billion of euro. So there's no formal adoption. I think today there's actually a decision that has to be taken. So there's no formal adoption, but there's already some agreement on like budgetary aspect within the Horizon Europe, but no formal adoption. So we'll have to wait, but we know that there will be the participation of African country, either through other partnerships with European country and in the different thematics that I will mention right now. So there have been different success, and part of them, of course, let's say, talk a lot to what you are doing in terms of connecting the scientists from one side to another side. This has been done under the H2020, for example, by funding some specific Marie Curie action. So we had some success, no, and you can go on the website and look that both for the Comrade project that was targeting a platform for intelligent collective resilience to help the community to address the conflict or crisis situations. We had also the African bioservices that was focusing on enhancing the biodiversity and also targeting the Great Serengeti Mara ecosystem. So there have been different success under the, just in terms of future priority, this has been already underlined. If you look on the international cooperation website, now called INTPA, before called DEFCO, you can see that infectious and parasitic disease are among the top, of course, priority beside the sustainable agriculture, sustainable energy sourcing, and the attention to the climate, the effect of the climate change, or more towards social, let's say, social economical issue, such as extremism and forced displacement, migration, etc. So those will figure under the priority, let's say the STI priority for the cooperation with Africa. So This mean concretely that when there will be projects open where different actors, university or other type of organization could apply in partnership with African organization, there would be this target, let's say, priorities in terms of thematic. That will be very important. So I'm not taking more time on this. This is the last part of the cooperation we are doing. This is now at the level of the Joint Research Center. The other one was at the level of the European Commission, but then more focusing on, let's say, science to inform policy activities. We are running a cooperation. I have my email, but this cooperation is clearly aligned with 3 of the 5 priorities proposed by the European Commission External Action Service and the DG INSPA, or former DG DEFCO. And the priorities underlined under the new proposed EU-African Union partnerships, of course, are green transition, energy, digital transformation, sustainable growth and job. There's also peace and migration, but for what we are doing here at the GSC concerning smart specialization, we align clearly with how to select the innovation priorities, the innovative solution in those fields that can help address the sustainable development goal, or the customized version of or the localized version of this challenge in the different territories. So just to finish my last slide, we did, of course, some specific, as I was saying, science for policy cooperation. We started under the smart specialization program with Rwanda, and we're running some specific program on Cote d'Ivoire and Nigeria, but they remain really exploratory and scientific. The main aim is really to inform what we have seen as the emergence and the rapid development of innovation policy framework on the African continent. So smart specialization would come as an approach, as an innovation governance approach to target some specific transformative activities, considering the limited resources of this region. So the cooperation is still ongoing and is under the broader EU-Africa cooperation for sustainable development goals. Thank you. I hope I didn't take much time.
Merci beaucoup, Madame Dosso. Et merci, c'est très intéressant.
Yes, thanks a lot.
Merci à vous. Et donc, maintenant, je cède la... Ah, on peut vous parler maintenant.
Je ne voulais pas essayer pendant la présentation pour ne pas vous perdre, mais oui, c'est bien moi.
Mais ça a très bien marché.
Merci.
Je vous remercie beaucoup votre effort. Donc, maintenant, je vais vous présenter, mais presque tout le monde le connaît, les professeurs de la technologie de l'image de l'Université de Las Palmas de Gran Canaria, Monsieur Juan Ruiz Alsola. C'est lui qui va modérer les présentations à partir de maintenant. Et c'est le promoteur aussi, ici aux îles Canaries, de les formations de thérapie guidée par l'image et d'anatomie digitale. Donc, je vous cède la parole. Go ahead, Juan Ruiz. Merci beaucoup d'être ici.
You're muted.
Thank you very much, Nasara. I would like to start by thanking all the institutions that support this event and the regional government of the Canary Islands for organizing the event. I would also like to thank all the speakers and participants in today, and the whole NaMic community that has been so supportive to make this possible. I would like also to highlight part of Dr. Mafini Dosso talk, as it is clear that there is a European priority to build these science and technology-based collaborations between Europe and Africa. And I think this is an international challenge that we are happy to collaborate from many different points in the world. So that's somehow what we are trying to do. We are trying to work together, building a large community. And I think that that this is the right moment that I give the floor to Professor Ron Kikinis. He's the principal investigator of the NaMic community. And thanks to his collaboration and his colleagues and all the NaMic community, we have made a great advance, and we are here today. So, Ron, please, you have the floor.
Thank you. It's quite a pleasure to be here. It would be an even greater pleasure to be on Gran Canaria in person. But of course, we cannot do it right now because of COVID. So we heard in the beginning about the political backdrop. These are all forces that put what we want to do in a very good framework. So I think to me it was interesting to hear all the support that we can get on multiple levels. What we will hear now is going back to the more hands-on work that we actually do in this program. And we decided as a strategy to work with academic teachers and help them become better teachers and provide them with a more powerful technology. That's where the Train the Trainer program comes from. So we will hear about the program, and then we will hear reports about some of the progress that we have achieved, given that we have been working on this now for several years already. And with that, I'll give it back to Juan Luis.
Thank you very much, Ron. So I am passing now the floor to Professor Tina Kapoor from Harvard Medical School and Brigham Women's Hospital, and she will talk about the overall. She will make an overall assessment of the African participation in our NaMic project weeks. So Tina, please.
Thank you, Juan. Greetings, everyone from Boston. I'm honored and delighted to be here. And I have to say that as Ron mentioned, I would much rather be in Las Palmas rather than in Boston, where we have about a foot of snow on the ground right now. I am going to tell you, the story of our project week. Let me just share my screen here. Okay. Just a check. Is my screen sharing? Could you see my slides?
Yes.
Yeah.
Okay, perfect. Thank you. So the thing I will talk about today will be what how the African countries' participation in Project Week has progressed over the years. Project Week is about building communities, and some of us have met in previous meetings, and this is the story of Project Week. The first chapter in our story was focused on building open science communities that were primarily based in North America and Europe. Now, we are in what we call Chapter 2 of the Project Weeks, and I'm delighted to say that what we've been seeing in the last few years is how these partnerships have expanded to African countries, and all by using community-based open source hackathons that are focused on medical image computing. Now, the story of Project Weeks started in 2005, just to give you some background. It was before the word hackathons was commonly used. And what happened then was that the US National Institutes of Health funded us to develop tools and to share them across the country. Ron was the leader of this project, and he asked me to lead the outreach efforts back then. We were excited. It was a large task, and we knew that we had to be creative in how we manage involving states within the US in the common development and extension of tools. And the diseases we focused on at that time were Huntington's, autism, lupus, and schizophrenia, to name a few. And we started in, so the first Project Week hackathon that we held was in July in 2005 at MIT. And this, on the top right, you see a picture of the MIT building that some of the Project Week attendees here, including from African countries, have visited. And this, at that time, we were all funded. It was a very different type of Project Week. We were all funded by the same grant, and we knew exactly what we were supposed to do. And most importantly, we were paid to show up for these meetings. And today's Project Week is very, very different, and I'll get to that. The biggest thing when we came together in the Project Week format, which is all people who were interested in the topic got together and brainstormed about what is it that we need to do to be able to do effective outreach of the tools and technologies we built. And the biggest breakthrough that happened there was the adoption of a software license, a BSD-style software license for our software 3D slicer, which allowed us to freely share it with any institution, not just within the US, but anywhere around the world. And this was a very key decision that has allowed us to progress and get to the point where we are today, and including all the impact that we are making in the partnerships with our African colleagues here. So fast forwarding a little bit, the first decade of this community building that happened was from 2005 to 2017. And we held 24 Project Week hackathons, and mostly they were held at MIT. And as I mentioned, the participants were North America and Europe. And our funding for the main NIH funding for the project at that time concluded in 2015, but participants continued to join from independent projects funded throughout the world. And the folks, it's an important thing to notice that when people continue to participate in Project Week, they're signing on for a very large commitment. And this commitment is both on part of the organizers and part of the participants. We hold this meeting twice a year, and it's the planning for it. We do it very carefully to make sure that there's content experts in the meeting, and there's also a fair number of first-timers with new ideas to seed the next generation of Project Week events. And fundamentally, people have to share a desire to collaborate and help each other. And when we're doing these hackathons, it's not just about showing up and working there. We start preparing for them about 10 weeks in advance. So people who come to Project Week, including the participants from our African partnerships, they have been attending Project Week phone calls every week for 10 weeks. And that's when we identify what are the projects of mutual interest to people who are going to be at this meeting. And this has been going on and building communities for all these years. And I have to say that in 2017, a very, very fortunate event occurred, which seeded the current partnerships that we have with the African countries. And here's what it was. So Juan Ruiz attended the 25th Project Week in Calabria. And at that time, so this is a picture from that Project Week, and some of the participants maybe recognized themselves here a little while ago. The focus, some of the projects that we were working on at that Project Week included virtual reality, ultrasound, the use of ultrasound imaging to guide surgical navigation, and prostate cancer interventions. These were just a few of the projects that people were working on together. And Juan started to become quite interested in the opportunities to take some of these technologies and start, the seed of training the trainers back in Las Palmas so that he could continue on to the bridge to African partners, as has been mentioned in earlier talks. And then after the after the Calabria Project Week, then Juan came to MIT in January of 2018. It was yet another snowstorm. And he came and he talked to us about, this was the group of participants at that project week. And Juan really started talking to all of us about the importance of the bridges that could be built by using open science, our open-minded community, and how technology could be transferred. And right next to Juan here is Mike Haley from our group in Harvard, who really, as they say here, drank the Kool-Aid. And he became a local proponent, along with Ron, of this idea of building and walking on this bridge. And there was more. It was, Juan didn't just stop at coming and giving a talk at MIT. He really put this idea in our heads that we should move the next project week to Las Palmas. And as attractive as Las Palmas was as a location, we wanted to be there, but it was quite a bit of a hurdle for people to travel all the way to do a project week. And we use substantial internet connectivity when we are doing project week, because there's about 100 people all writing software with 3D Slicer, which does take up a fair amount of internet bandwidth. And so we were not sure how that would go, but given how determined Juan and his team were, we decided that, okay, this was worth a try. So we brought the 28th project week to Las Palmas in June 2018. This was the first time that there were face-to-face meetings between the communities, and at that time, 8 out of our 58 participants were from African partnership countries. So Senegal, Mauritania, Cape Verde, and Mozambique were represented then. And one of the very, very interesting things that we all noticed at that time was that the internet connectivity in Las Palmas was perhaps even better than what we had here at MIT. So again, these bridges and the infrastructure that had been built for years in Las Palmas was really helpful in helping us bring our technology there. Then, since then, so given how important that technology, the internet connection, and the teams coming together on projects of mutual interest is to us, we took up Juan and the team and started to have project weeks in Las Palmas annually. So this is a big thing for Project Week, to have a second location. The primary location is MIT in Boston, and our second location has now been fixed to Las Palmas. And the focus of the projects that have been developed here have been digital anatomy or anatomy atlases, image-guided therapy, and virtual reality, to name a few. The participation of colleagues from African countries has grown. There were 11 in the 30th project week, 11 again in the 33rd project week. And the 34th project week is what we're holding right now on the internet. And as disappointed as we are that we couldn't be in Las Palmas, but let me show you this. We have almost 200 participants in this project week, because we were able to hold it on the internet. And the next slide is the one that has made this one of the happiest project weeks for us, is that 56 of our participants are from African countries. And so we have 22 from Sudan, 16 from Senegal, 7 from Morocco, 5 from Ghana, 5 from Mauritania, and 1 from Mozambique. So in terms of the accessibility of our Project Week Open Science community to African countries, I think this is a milestone Project Week. And what I'm going to leave you with now is that later in the program, you're going to hear about very specific contributions that have been made by the African partnership, the African community in partnership with Project Week. And these will be 4 presentations. And we can talk about I can talk about Project Week for a long time, but I will leave you here with the website where we've listed all of our events. We really are good about capturing data. And my email address is at the bottom here, so I'd be very happy to answer any questions. And now I will pass this back to Juan.
Okay, thank you very much for your presentation, Tina. And then next speaker is Dr. Ekwa Nwama Bentil. She's an educational specialist from the World Bank, and she's the leader of the Africa Higher Education Centers of Excellence program at the World Bank. So Ekwa, please have the floor.
Hello, can you hear me okay?
Yes.
Great. Thank you so much to the organizers for the invitation to present today about the work that we are doing at the World Bank and the Africa Centers of Excellence programs. So today I'll just walk you through some of the work we're doing, and then also ways in which we partner with whether it's academics or the private sector, and what we continuously support our centers to do. So I'm going to share my screen. If you give me a minute here. Do let me know once you're able to see.
Okay, it's okay.
Great. Let me go to. Is it good?
Yes.
Okay, perfect. Okay, so just to speak a little bit about this project. So it's called the Africa Higher Education Centers of Excellence program. And the goal is to basically build capacity in Africa to address Africa's development challenges. And so far, many of the speakers today have really addressed the spirit and the objectives that this program is all about. Just broadly, within the World Bank, about 1.4 billion of current investments are in higher education. And within that, within this funding scheme, we have about 20% of the overall education budget in higher education, and 50% of that is in the sub-Saharan Africa region. The ACE project, that's what we call the Africa Higher Education Centers of Excellence, we call it the ACE project, is within this funding scheme, and it is a regional project. And so, and it's found in several of the countries that I'll show you later on today. But this slide here is just to highlight the fact that the World Bank has been doing a lot within the higher education space within the past few years, whether it's around regional projects or it's around national projects, or basically supporting countries with analytical work. So what is this Africa Centers of Excellence program about? So the objective is basically to promote and improve education, training, and applied research at the postgraduate level. So we look at mostly the master's and PhD levels, and in various priority fields, cutting across the STEM areas, agriculture, health, and related fields. And the reason why it's a regional project, and the some of the advantages that brings to the continent is that it supports the pooling of resources, right? Because the idea is every African country does not need to have excellent programs in all of the priority fields, right? And that'll be very, very expensive at this point. But the goal is, can we have poles of excellence in different countries that can provide the needed training, and the different countries can send students across borders to get these trainings. And the idea is to ensure that the critical skills and applied research needs that are common across the countries can be addressed. We use a results-based financing approach where all of the funding is tied to achievement of results. So the centers need to meet certain results in order to get funding. And we look at strengthening international specialization of the graduate programs. We also really look at providing learning resources, labs, and minor rehabilitation to ensure that the learning environment is strong. We also promote establishing regional thematic networks. So we have centers in mining, in water, in infectious diseases, in agriculture, and so on and so forth. And then also we promote specialized short courses for industry and ministries so that they can go to these centers and take short courses to upskill, themselves. And then there's a very strong emphasis also on linkages with companies and also partnerships with academic institutions, governments, and agencies, because the idea is that we don't want these centers to exist in a vacuum. They need to be strongly connected to their communities. We have a series of 3 projects that have been supported under the ACE program. We had ACE 1, which started in 2014, was launched in 2014, and was just wrapped up. It closed in 2020 of March, where the World Bank invested $165 million across 22 centers in 8 countries in the region. And as I said before, the key features that is results-based financing to ensure that the centers are incentivized to meet certain milestones. And then in 2016, ACE 2 was launched. So just to indicate that ACE 1 was in Western and Central Africa, ACE 2 was launched in Eastern and Southern Africa, where 148 million was put into that. And there again, the idea is to also follows the results-based financing. And some of the unique features of that was that centers where we ensured that they had what we call institutional benchmarking, where they had to collect the data and then have some funding attached to that, because data is an issue within the continent. So we wanted to push that agenda a little bit. And then more recently, in 2019, we launched 2 sets of projects. They're very similar. The only difference was the countries that were participating. So across 11 countries, we have about 53 centers that are being supported. And that cuts across Western Central Africa, but also includes Djibouti. I'll show you a map of where these centers are all located. And this is being co-financed with the World Bank and the French Development Agency, AFD. And one of the unique features of this particular series was that we had pre-identified thematic areas that were put together that universities had to apply to participate in. And also we had very strong upfront engagement with industry. Hopefully we can share these slides later on for colleagues to take a look at. So ACE 2 is still ongoing on Eastern Southern Africa side, and then ACE Impact is also ongoing now for the West and Central Africa region, but also includes Djibouti. This gives you a sense of the different countries where the centers are located. So across from ACE 1 through ACE Impact, it's across 20 countries and about 76 centers. And you can see there's ICT, there's water, there's transport and logistics, there's energy, there's health as well. So now just to zoom in terms of the health centers, since for the sake of this workshop, I wanted to highlight some of the areas that we support the centers in. We have about 100 million that's going towards the centers, and out of the 76 centers, we have about 13 of them from the ACE impact in the West and Central Africa side that are in the health sector, and 5 in the ACE2. So we have centers that are in the infectious diseases area, pharmaceutical sciences, herbal medicine, and food safety. We have nursing, we have reproductive, maternal, and infant health, and genetic medicine. On the right, you can see some of the target indicators that these health centers have set in place. But just to know that although they have these targets, one thing we've seen is that the numbers, it was launched, ACE Impact was launched in 2019, and these numbers, in some cases, particularly the student numbers, we're already doing very well, and we know that they would exceed some of these targets. So again, I will make sure we share this slide for participants to see some of the detailed areas that the centers are participating in around infectious diseases, around reproductive and maternal and infant health, genetic medicine, and then also pharmaceutical science and herbal medicine. So from epidemiology, we have bioinformatics, we have nursing, we have various fields, as you can see here. And we also have a list of the centers. You can see in terms of the countries, they are across various countries and then several universities as well. We have Ghana, Nigeria, through Burkina Faso, Guinea, Zambia, Tanzania, Malawi, Ethiopia, Uganda, Senegal. Now I'd like to just show a few results that we've and successes that we've had. So under ACE1, which was launched in 2014 and is now closed, but has been taken over by ACE Impact, several of the centers, about 18 out of the 22 centers from ACE1 actually are now still being funded under ACE Impact. So you can see that the funding goes towards support to increase student enrollment. And you can see some of the numbers for masters and PhDs. We are very pro international accreditation and work very closely with a lot of the international accrediting bodies globally so that our centers can work with them to ensure that the programs are top quality and at international standards. And also we encourage them to generate external funding through R&D grants, scholarships, and various other means. And from the ACE1, projects, it was an excellent project, had very strong results, and hence the World Bank was willing to put in additional funding under ACE Impact. And you can see some of the pictures of what it's gone to support. And there is one also, we had a center that was able to diagnose some of the first cases of Ebola when it came up, and it's accredited for helping stop the virus from moving around in Nigeria. And it's it's the ACE Center. I'll say a little bit more about that center later. We also have various testimonials from students from Ghana as well. So at least we know that the centers are making some impact on the ground. So within the whole COVID response and impact, the centers have been at the forefront, whether it's around genomic sequencing, mass testing, modeling of the spread, training health workers, leading clinical trials, and then also, our engineering centers have done a lot of work around 3D printing of PPEs and designs of ventilators, developing various types of apps, hand washing equipment, and then also there's been a lot of community outreach, particularly the health centers within their communities. And at the project level, we've also provided a lot of support to the centers around connectivity, where we've allowed them to adjust their work plans to accommodate connectivity for their students and their faculty members, communications, also digital content and platforms access. We've worked with a lot of different providers on that, and also a lot of capacity building around the use of digital education resources. How do they develop online programs and also deliver it? And I did see that that's an overlap with some of your programs that you have as well. And at the national level, the World Bank is also supporting countries through various elements as well. So just to highlight some of our centers, the health centers and the work that they've done. This particular center, ACEJID, has been a very strong player in Nigeria and around this whole COVID crisis, and has gotten a lot of awards. And I do also like to note that they've been working on a vaccine candidate, which we hope can go far. We also have another center in Ghana that has been one of the venues for mass testing. And then another in Burkina Faso that is doing a lot around providing pharmaceutical expertise. And another one also in Burkina Faso that has been doing a lot of different clinical trials for treatments for the COVID epidemic. And one of the things points I would like to make here is that it's amazing that these centers were able to go out there and make a difference because they had now the capacity to do so through funding. And they had people that were trained to do so and had the equipment to support their countries. You can imagine if they had to send samples outside of Africa and the time it would take. But the good thing is our centers have been able to provide some of these supports within the continent. We have many, many more. We'll share these slides for you to take a look. Now, my final slide on areas where we could collaborate. So we encourage our centers to look into academic partnerships, and that is around students and faculty exchange programs. That's around research collaborations that it can have with various partners across the globe. Also, they can invite international experts to serve as scientific on their scientific advisory boards. And do I go on? Okay. Okay, and then also joint summer schools and seminars and workshops. We also promote our centers to really dive into industry partnerships because the health sector, as you know, is very nascent on the continent at the private sector level. So we hope that this would grow through some of the innovative work that our centers are doing in collaboration with partners within Africa and outside of Africa. One point I would like to make before I move off of this slide is that, we are always looking for partnerships across the globe. There are times when we have granting agencies that would do a call for proposal and reach out to us to encourage our centers to partner with centers within other countries to come together and apply for some of these grants. Because as you see, it's a global community, and the more we can work together to solve some of these issues, the better. Thank you very much. If you like more information, we have this website available on the slide. As I said before, I will share the slides with the organizers. We also have the list of all of our centers across the board with the contact details of our center leaders, and would like to continue this relationship. Thank you again, and also special thanks to Juan for making this happen. Thank you.
Thank you very much, Ekwa, for your presentation. And the next speaker is Dr. Nasreddin Ouseddoun from the World Health Organization in Mauritania.
Thank you very much. Thank you, Professor Juan. Thank you to all the organizers for giving me the opportunity, to participate in this very important workshop. Can you hear me, please?
Yes, yes, we can.
Okay. So I'm going to try to share my screen. Unfortunately, I do not have a good connection with the internet, but can you see now?
Yes.
Okay. Today I'm going to walk through the, our experience with the training regarding the, the participation in this workshop, and also the use of technology in the health system in Mauritania. So basically, the training of our participation in the training was at the WHO office in Mauritania. We provided technical support to the Ministry of Health that started in May 2020 this year during the COVID-19 crisis, the COVID-19 pandemic. We got funds, and we supported the Ministry of Health through the recruitment, training, and deployment of 100 consultants. Most of these consultants were recruited from the school, med school in Mauritania. It was an intensive training, mainly for the basic epidemiology and main component of the surveillance of COVID-19. We trained in almost 10 days. We trained 2 cohorts, each composed of 50 students. Some of these people were already doctors. Some of them were public health professionals, but most of them were students. And the training was mainly, as I mentioned, regarding the basic epidemiology and surveillance. Due to that training, shortly after finishing the training, we helped the Ministry of Health to deploy these people throughout the country. So they conducted, until now, work is still ongoing, the surveillance, COVID surveillance in the 15 regions of 57 countries, 57 districts. So basically, that gave us the opportunity, to track all the indicators of the surveillance and to detect and give the right response on time with regard to the COVID. So now these more than 100 people are deployed all over the countries. They are present in all 57 districts of the country. Now I'm going to walk through the view of WHO regarding the use of technology in public health. Just very quick, few words about the GPW13, those of you who are not familiar with, the WHO Triple Billion Agenda. The GPW13 is mainly summarize the WHO mission, which to promote health, keep the world safe, and serve the vulnerables. It is structured around mainly 3 priorities. So it's achieving universal health coverage, addressing health emergencies, and promoting healthier population. That was mainly, discussed during the World Health Assembly in May 2018. And the main target was to achieve that 1 billion more people could benefit from universal health coverage, 1 billion more people could be better protected from health emergencies, and 1 billion people will be more enjoying better health and well-being. And all of that would lead us to the main points, which would be basically built, especially through the digital means, capacity for human resources for digital health as appropriate across both health and technology sectors, and to communicate area of specific need to WHO in order to receive appropriate technical assistance. So WHO has, developed global health strategy on digital health, which covers from 2020 to 2025. I'm not going to read the slides because you will have the opportunity to view them with a clear vision and clear mission, but I'm going to go straight to the main points regarding the experience at the in the Afro region and in Mauritania with regard to the use of technology. to promote health and especially public health and epidemiology. So in the Afro region, there are several projects running and for the last few years, and most of them are related to the polio and other diseases preventable by vaccines. A few of them are, as you can see in the slide, AVADAR, which is audiovisual AFP detection and reporting. This is mainly for polio. As you know, the polio is, we are about to eradicate polio, and for the surveillance is the main component now for, to fight the disease. We are in the last mile of the eradication. And that's why the surveillance is very important, and the use of technology is being, promoted for the last 10 years. So the AVADAR is one of the tools that's being used since 2017. ISS is another tool, which is called integrated supportive supervision, also electronic surveillance, DEM maps, and the vaccination tracking system. Just to give you some data about regarding the integrated supportive supervision. In 2018, 48 countries were enrolled in this program, and over 160,000 ISS visits were carried out from January to December 2018. These ISS visits were very important, not only for polio. This is where actually all this work was done through the technology, which is geographic information system. Basically, these visits were very important, not only for polio eradication and surveillance, but also for all the component of routine expanded program for immunization and surveillance for disease preventable by vaccine. Because when health workers use this technology on their mobile devices, they go to the health facilities, and in that health facility, they need to be geolocalized. And that will transmit the information on the server, either at the country level or at the regional level, and that information will be captured. And there will be going over 64 questions that mostly capture all the information related to disease preventable by vaccines, which picture taking regarding the cold chain and regarding other very important aspects of the immunization. And all the information will be captured, analyzed, and at the same time, there will be some on-site training. So as you can see, the information can be given to the supervisors, and you can take action right after. The other tools which is also have been used with regard to the GIS is vaccination tracking system. As you can see, this is one of the pictures that was taken in one of the sites, and you can see the geographic coverage is 92%, as you can see with the covered area on the green. So that's for the Afro region. For in Mauritania, where I'm working right now, WHO is supporting several projects. One of them is DHIS2, Digital Health Information Software. That's, I will talk about it a little bit later. And ODK, that also another software which is used in integrated supportive supervision, and mid-level manager of immunization program, training of immunization program. That also is another program which is about to be introduced, and telemedicine that has been introduced since 2016. For the DHIS2, those of you who are not familiar with it, the DHIS2 is a very important technological tool which was developed by Norway University. WHO is supportive of that project. Is mainly is a free open software. Is gives the capability to it have an analytic package for aggregate data collection package, and also for the tracker system for individual data. And one tool is for data quality. The DHIS2 application mainly is the data are captured in the field, then it's transmitted to the system, and there will be a quality check, and then it will give you all the analysis based on the indicators that were set up in the system. The software were introduced in Mauritania in 2017, and now it's being generalized for the whole country. You can access the information. For now, you can access the information everywhere in wherever you are, if you have the internet connection and you are given the accessibility by the administrator. depending on the level in which you are, depending on the, if you are an administrator or if you are a manager of the site or if you are just a health worker, everyone, depending on his level, is given an opportunity to access whatever that is in his capabilities. So the other information is regarding the information cycle of the DHIS2 is enable you to collect the data, run the quality check, give you the data access at multiple levels, reporting, making graphs and maps and other forms of analysis, and enabling also comparison across time. Also see trends which display data in time and series. Now, there are some unmet needs which really are very important for the future to look at them. One is electronic learning for health workforce. This is a lot of room is still not only in Mauritania, but also in the African region. I know you've been working a lot on this, but I want just to give you, based on our own experience in Mauritania and in the African region, this is very promising space, especially for the health workforce. Disease surveillance and prevention and control, and routine and data quality of health for decision making. E-learning, with regard to e-learning, the technology can help us to support the curriculum, also the course scheduling, the management, and to train, deploy, support, and empower health workers. It can also optimize the work of healthcare providers, the use of electronic health record, clinical decision making, supply chain management, and service quality control. And lastly, it can also facilitate the health communication, continuing education. This is a great opportunity, especially as we learn from what is going on with the pandemic. The other component, which is very important to us, especially as we now, living with COVID-19, the disease surveillance and prevention. Digital technology, as you know, then that can help us, quickly detect and predict disease outbreak using the internet and mobile phone application. We have some of these applications already in the field and that are being used, but if we can move to, more web-based surveillance tools that are, applicable, especially at the community level, that are really not very expensive, that are really can be managed by the people at the field level, and that can give us the possibility to collect very quickly and analyze these data and get them as soon as possible. That will be very helpful, especially for the future. This digital tool for epidemic can also be used for epidemic modeling in order for us to predict and prevent future infectious disease. And one of these also things which are very important is the health data. As I mentioned during one of these slides, there are a lot of data who's available. So if we can use the technology, to create a platform that can integrate all available health data. We have a lot of health data, but they are not analyzed and they are not used. Among these data we have tons of surveys, routine data, surveillance, data on outbreak. If we can collect and analyze these data and give access to scientists, so these data really can be helpful for us. If we can provide access to local and international public health researchers, that can serve for developing a knowledge network for not only for the country, but also for the region and elsewhere. And lastly, in my last slide, I would like to emphasize on, if we can use the technology to improve the collection, storage, and saving, analysis, access, and dissemination in order to guide healthcare professionals, administrators, decision makers, and even funding partners to take evidence-based decision. This mainly will be around the main, among others, that birth registry, mortality data, biometric data, electronic maps with demographic data, community and sentinel surveillance that will be very helpful for the public health, not only for Africa, but around the world. Thank you very much again. And if you have any question, stop here.
Thank you very much, Nasruddin, for your presentation. So now we have an unexpected circumstance as Professor Yahya Fail from Mauritania has to leave the meeting and he'd like to say something. So please, Yahya, the floor is yours.
Thank you very much. Unfortunately, my collaborator in the hospitals told me that we have a patient. We arrived in an emergency and we have to operate him as soon as possible. So let me share with you my my screen. This is just to present for you the evolution of our anatomical atlases that we started since 2018 when I arrived to the NaMic Week project. Our team was working on several atlases on the same time. Some of them is already on the site of Open Anatomy with a cooperation with Mike. Our research project was to develop an anatomical atlas of human body, all of the human body parts. Data has been collected from several local hospitals and also from the website. We use MRI and CT scans imaging data from both child and adult systems. Our objective was an innovation of the anatomical teaching in the medical schools of Nouakchott by the creation of human anatomical atlas as a new pedagogical tools in the Faculty of Medicine. Creating an anatomical models using 3D slicers, segmentation of whole parts of the human body, export models obtained from the segmentation into the open anatomy structures using the web atlas editors. Approach was in 3 dimensions. First one was segmentation using 3D slicers, modules, and extensions. Undergraduate training using the 3D slicers segments when they are using the pilot group was 8 students, and the sex ratio was 1:1. That means 4 females and 4 males. Segmentation of different and complete parts of the human body. Innovation and finishing the annotation. And the result, this is a screenshot of the brain segmentation, and this is of the liver segmentation, and this is of the abdominal parts segmentation, and this is of the upper limb segmentation. Thorax, as I mentioned before, is already you can see it already existing on the Open Anatomy. Just by one click, you will see that it's already present on the Open Anatomy with the cooperation of Mike. And we appreciate that all the support that he does with us. And for the others, we are ready to finish some. This is for the arms and the forearms, and this is for the hand. I want to share with you. This is animating structures of the hand. It will take around 55 seconds, less than 1 minute. This is done by our students. They are doing a nice and well done work, as you see, and we encourage them to continue for that, for this work. It is a very nice work, despite of our CT scan and MRI tools with poor quality, but with that, they still doing a good things. On the other side, we are working on this on the translation, and we do most of the parts in French, Spanish, English, Latin, and Arabic. And Naira, he's already, I think Professor Muraidri sent her these works to be integrated in the atlas. But last week sent us an email. There is some problem in the keyboards, doesn't know Arabic letters, and we will see how to arrange for that. And this is the last models of the brain segmentation that's done by a clever student of our team. And as most of you know that we are trying to open the IGT centers. The building is already exist, but the equipment is in the way. And this is some screenshot of the translation of the anatomical atlases. And this is the image that was seen by one of the speakers before of our team working on the IGT sittings in the faculty. And this is another way. Thank you very much for that. And I am sorry to not finishing with you because our emergency. And Professor Muraidri will be online to if there is any question for that. Thank you very much.
Okay. Thank you, Yahya. So we then continue with the program, and our next speaker is Professor Alexandra Golby from Harvard Medical School and Brigham and Women's Hospital, and she's going to talk about neuronavigation in surgical planning. So Alex, you have the floor, please.
Thank you very much. I'm going to share my screen. Okay, does everybody see the screen?
Yes.
Yes, okay. Well, so I've enjoyed very much listening to the meeting thus far, and especially actually a good interlude we just had, because it sets the stage for what I'm going to discuss, which is a much more zoomed-in view. So an idea about how we can collaborate clinically and technically to create a tool which will help neurosurgeons do better neurosurgery. And obviously, in the grand scheme of health needs, neurosurgery is a small area with small numbers of practitioners, but it's also been traditionally a real leader in technology and methodology, starting with in our own country, where neurosurgery really led the adoption of imaging, of the operating microscope, of adjuncts to surgery that improve outcomes. And so I think it can serve as a good example and an opportunity to really push technology and demonstrate to others the value of technology. So I've been lucky enough to collaborate with numerous people from Mauritania last year during our visit, during the last project week, and also in East Africa. And I'm going to start by just saying that there are large numbers of neurosurgical needs, and a lot of these are unmet needs. And surgical disease in general plays a very big part in the top 10 sources of morbidity and mortality across all age groups. In neurosurgery, like in healthcare in general, I really think about it as a stool with 3 legs. And all 3 legs are important in order to get the very best outcomes for the most numbers of patients. And you've heard today about really exciting, broad and deep training efforts. And that is, of course, the first and most essential piece of this stool. Without the trained practitioners, without the trainers, as we've been talking about today, train the trainers, then infrastructure and technology are not useful. So I do want to emphasize that. But with an increasingly trained workforce, with the types of initiatives that you heard about earlier, they need the infrastructure and technology to really leverage what they have been trained to do in order to be able to practice at the highest level of their training. And so in terms of how this translates to neurosurgery, the goal is to give neurosurgeons the kinds of tools which will allow them to have better interventions for their patients. And in particular, when we talk about neurosurgery, we talk about injuries which are often lifelong and life-altering. So any improvement in neurological outcomes has a very big impact. And also many neurological diseases impact children and young adults. So there's a lot of years of life. This is to show in background the neurosurgical workforce. And you can see that in Africa as a continent as a whole, there are low numbers of trained neurosurgeons, but this is changing. And there are efforts afoot to train more and more neurosurgeons who in turn train other neurosurgeons. So there's been big efforts in Morocco to train Francophone neurosurgeons, in South Africa to train Anglophone neurosurgeons, and also efforts spearheaded by individuals. So one of my colleagues is Ben Worf, who developed a hospital in Uganda specifically to treat hydrocephalus, and developed new approaches in using endoscopy. So again, new technology, and using that technology to develop an entirely new way of treating hydrocephalus, which does not require placement of a shunt. And since that time, not only has he treated hundreds or thousands of patients, but he has trained about 100 other practitioners in the use of the endoscope to treat hydrocephalus. So workforce training is very important, and the ability to collaborate with platforms such as what we're doing today, but also to collaborate when we're looking at the data, looking at particular patient cases. So especially for practitioners who are often working alone as not part of a larger group of similar specialized practitioners, it's very important to be able to have collaborators who may be at a distance and to have a platform for collaboration where you can review images such as, in our case, CT, MRI of patient brain. And obviously infrastructure also is very important. So the use of the staff and the practice and the patients have to come together in an operating room with the sufficiently trained staff. In neurosurgery, imaging is a critical piece of what we do. It allows us to look inside the head. Medical records, and we heard a little bit about this, and the importance of digital data, so the ability to keep records which can be accessed. Having access to a pathology core is very important, and this is an area where I think digital health and telehealth will be very important, as once the slides are available to be digitized, then remote consultation can be used. Intensive care is another area. So this is an area where Telehealth probably isn't so helpful, where you just need the personnel. Actually, our country, which should be an example right now, is suffering from a lack of intensive care unit beds. And then other important things like laboratory and blood bank. I wanted to talk just quickly as a point of start of discussion, and also I hope a start of collaboration, because we really would like to have your input into what is helpful and most useful. So as I said, neurosurgery is a very high-tech specialty, and we depend essentially on imaging, usually CT and MRI imaging. We also require high-level monitoring and anesthesia, and intraoperative visualization if possible. And this is a picture using ultrasound, which can be acquired in real time during surgery. And in this case, you can see the definition of a tumor and of edema and some orienting structures such as the ventricles and the falx. So imaging really changed what we do in brain surgery. It took us from the era of Cushing, where the head was opened without knowing what would be found, without really any guidance, to the ability to see beforehand, before surgery starts, what the target is. But in order to achieve the full benefit of this, we would like to try to make a link between the imaging and the operative field. And we do that through a tool which is called neuronavigation, which is similar to GPS for the head. And in the same way that GPS was a technology 30 years ago, 25 years ago, which was very expensive, very bulky, very cumbersome, and which now is available on every smartphone at low cost, with actually greater precision than in the old GPS systems. That's our hope for this type of technology, which leverages 3D cameras to create a GPS system which can orient the images to the head itself. And then, as I mentioned, further refinement potentially with ultrasound, which can be a relatively low cost and low workflow disrupting technology. So how does navigation help us? Well, when the brain is exposed after the craniotomy and the opening of the dura, in theory, you could look at the surface as depicted in this picture and see that the tumor is where the tumor is located by the anatomy. But in reality, this is often not the case. Often we look at the surface of the brain and it looks completely normal. And obviously the brain is very high stakes real estate, and we don't want to remove tissue that could be critical for functions such as motor or language function. So the ability to have annotated data which can help guide the opening into the cortex can be very important. It also provides some other benefits, such as the opportunity to interact with the data, the imaging, before surgery. So to look from different planes, to slice through in non-cardinal planes, or what we call oblique or inline views. It can allow us to make smaller skin incisions and smaller craniotomies, and in so doing, decrease the risk of certain complications like epidural hematoma, subdural hematoma, also better wound healing, shorter hospital stays. It can avoid wrong site surgery by the use of navigation, which is extremely important. And as I said, it can provide guidance while doing surgery, particularly for deep lesions. So our goal is to create an affordable, off-the-shelf and open source technology for modern neurosurgery, which would be available and which would hopefully democratize this technology. To take these tools, which in the US cost hundreds of thousands of dollars for the navigation, the surgical microscope, the ultrasound system, and adapt it to take advantage of some of the consumer electronics advances that have been made. So this is an example of tablet displays. This was developed with Steve Piper, who's joining us today, to allow us to use the navigation system, which I'm holding in my hand, a pointer, to visualize where we are in the head. And our goal is to use other technologies such as 3D cameras, which have been developed for gaming, which can take the cost of the optical part of the system from tens of thousands of dollars to less than $100, and to use low-cost navigation. The premise of this requires that we fix the head, and this is one area I'm very interested in speaking to neurosurgeons, is the availability of Mayfield head holders, such as you see here in your hospitals. And then attached to that is a reference array, which is used to triangulate the position of the head and of the instruments. Our goal is to engineer these in a way that is less expensive and also does not use consumables. So we designing other ways of tracking, to develop software. And this is work that was actually really born at last year's Project Week in the Canary Islands. And you see here JC from Kitware, who has been helping us take tools from Slicer, which is an open source research platform, which you heard about already, and make them seamless for clinical application for individuals to use in their operating room. And we call this NuNav, new in part for novel and also in part for us in French. And the idea would be to use this for several stages. So as I mentioned, planning of the surgical gesture is very important. Looking at different approaches to a lesion, registration between the patient and the imaging, which is done with this type of surface matching that you see here, and then navigation, which is done during the actual surgery to help localize lesions or to place catheters for hydrocephalus or any number of other approaches. Our goal is to make the software intuitive and the workflow very clear, and so and to make it language independent as much as possible. So to use these types of images to help guide the clinician in the adoption of this technology. We're also very interested in leveraging advances that have been made in low-cost ultrasound technology. So this is an ultrasound which plugs into an iPhone. It costs about $2,000. It's being widely used in the US, for example, during the COVID crisis for lung ultrasounds in the emergency room without having to take the patient to a radiology suite. The clinician themselves, herself or himself, can do the exam at point of care. And that would be our goal for surgery, would also be to harness ultrasound, which is a real-time imaging modality available at point of care. We have to solve some issues related to sterility or draping of this device, and also how to help orient the clinician to these images, which can be difficult to interpret. So our goal is to put these things together, as I said, to leverage some of the consumer electronics, which have brought the cost and price point of these way down, to create a system that would be usable. And we really are very interested in your input in terms of what is feasible, what is not feasible. And our hope is to have a working prototype, both software and hardware, within the next 3 to 6 months. These are our collaborations. As I mentioned, last year we were in Mauritania, but we have a number of collaborators around the world. And our hope is to travel. I would like to go and try these prototypes and see your feedback and understand what we need to fix. But in the world that we live in right now, maybe we won't be traveling. Maybe we'll be working by Zoom and sending the system, hopefully by mail. This is just a list of some interested collaborators. I really hope, and the reason I'm here is to build more collaborations. And the reason to do that is to have impact, to give neurosurgeons the kind of tools that they can perform better surgeries, have better outcomes, take on more difficult cases, to train others and to be trained, on a collaboration platform, which allows us to, in parallel, look at the images and decide an approach, anticipate where the challenges might be, and teach and learn, creating a community of users. And the learning goes in both directions. There's no question about that. I was really moved to hear about the rapid deployment of a force to do epidemiology and tracing in Mauritania. You know, this is something the US could learn from you. So it's a two-way street. The collaboration is extremely important. So that's a little detour from where we've been talking into neurosurgery, neurosurgical technology, how we can work together and harness technology to do the best that we possibly can for our patients. Thank you very much for your attention.
Thank you very much, Alex, for your presentation. Then we continue with the program, and now we will have presentations from 4 African teams, and they will show how their participation in the Train the Trainers program has been along these years. So we'll start with Dr. Tawa Idris from Khartoum University in Sudan. Tawa, the floor is yours.
Yeah. Hello, good morning, everyone. Are you hearing me well?
Yes.
That's cool. Good morning and good afternoon, good evening. It's we are spread all over the world, and right now I am in Boston. We are freezing here. So, and so it's really my pleasure to be with you, and I'm so delighted and excited and also proud that I'm able to join this project week. And first of all, this can't be approached if I was not able to work with Dr. Ron, as he's my PI, and Dr. Gordon also is my PI at MGH, and being as a co-worker with Steve and Juan and Asma and Sonia and Naira, all of you. First and last, thanks for you. So starting with our participation, and I will give you a small hint about Sudan. And Sudan is a very old country, and it was extended in northeast of Africa, including Ethiopia and the south part of Egypt, and it is almost 2 million square kilometers, and it is the 3rd largest country in Africa and in the Arab world as well. And we are privileged that we have the two communication, the African and Arab cultures. And the Nile is a major north flowing river, and we claim that it is the longest river, though sometimes they say the Amazon one is the longest, but we believe the Nile River is the longest one. So at the confluence of the White and Blue Nile resides the capital of Sudan, the Khartoum. And we are around 42 million population. And Sudan is a very large country, as I said, so we are almost 597 tribes and more than 400 dialects, though the main language is Arabic, and the main language for education is English. Therefore, represent 30% of the general population, and its area is almost equal to France, so it's a large area. And then following this, following therefore, the rest of the population are condensed in the middle of Sudan, Khartoum and Al Jazeera at this area. So when we come to this just hold a second. And so generally, what are the changes that facing us in doing the scientific research? First of all, in the health services, there is lack of resources and infrastructure. If we just take a sample that we have regarding the oncologists, it's only 40 certified oncologists in Sudan. And if by calculation, that means every one oncologist to 1 million population. And therefore, as we mentioned, that it's they are 12 million population, but actually we have only one oncologist resides in Darfur. And Darfur has the highest number of cancer patients, mainly breast and uterine cancer, in addition to the prostate cancer in men. Following this, we have 4 oncologists in Al Jazeera. The rest of the oncologists, most of them they are situated in the Khartoum, in the capital of Sudan. There are areas in Sudan they do not have oncologists. If we came to the surgery, which is one of the important subspecialties in medicine, in Darfur, for all the 12 million, we have only 1 neuro surgeon, the urologist 5, the orthopedician 7, and the general surgeons are 10. And I'm not speaking about Darfur was a war zone during this area. And this is only an example because this is applied for all over Sudan, but this is the area that I was able to have the information. And also because we have the trainers program from Al Fashir University. So regarding the medical education, we have around 32 public medical schools all over the country. There are another around 30 something private medical schools, and therefore has 4 medical schools, but only Fashir University has its own dedicated complete faculty staff. The challenge is, of course, the very low salaries for the staff. And so that's why most of them, they are working between private clinics and teaching hospitals so they can satisfy their income. And there is lack of e-learning platforms. And this is more obvious now with the waves of COVID all over the world. The main problem really the isolated islands, because there is no available data, there is no cancer registry, there is no image repository. It was hard for me to communicate with the local authorities. I'm here right now in Boston doing my research at MGH, but having communication with the local authorities over there, it's almost impossible. And sending emails, it's just gone with the wind. So as the previous speakers, I'm not going to repeat that there is lack of infrastructure and technology equipment, of no doubt of that. There is very old basic science labs, and this is mainly for the training and education for the medical personnel. As I'm medical graduate, so most of my interests around the medical education, but this is applied for most of the science. And there is no funds for research projects. All the efforts, either individual or especially for centers of endemic and tropical medicine centers. And as I mentioned, there is no dedicated research staffs. So our experience with 3D Slicer and NaMic project is we are new to the NaMic and the 3D Slicer community. It's not as a personal experience because I have 3 years experience, but as a Sudanese community, we are totally new. We joined this program around 6 months ago, and we were honored to communicate with Juan and his team, and through Ron and Steve, and they were very supportive for us. And right now, the current NaMic program, around 20 medical professionals joined the program, and 3 digital anatomy atlases were segmented, not yet completed 100%, but some of them are really good. So starting with Group 5, Renal Cancer Atlas, this conducted by Fatah Rahman, Abu Zar Al-Tahir, Mahil, Kamal al-Din, and Al-Sadiq. And why they think that renal cell carcinoma is important to segment because formerly the gold standard for treatment was radical nephrectomy, and currently, the nephron-sparing surgery is widely used for small tumors. This necessitates that segmentation of the renal tissue with tumors in addition to the feeding blood vessels can provide a better assessment to the depths and extensions of the tumors. And so this might give a better surgical mapping. 3D Slicer gives an excellent visualization and segmentation tools to conduct such process. And the digital anatomy atlas of RCC, which is the renal cell carcinoma, can improve the quality of training. And as you can see here, this is a tumor. All the images were all the cases that we segmented in this project, we retrieve them from the TCIA. And this is also give the importance of open sources for the developing countries. So as you can see now, this is a volume rendering. While we have the segmentation, the segmented kidneys overlay the volume rendered images. And this is the tumor as we are able to see it here. And this is the relation of the tumor into the medulla. And this is how we can track biopsy line or surgery or minimally invasive. And this is very interesting for me because I'm a fully trained radiologist, and I believe this type of navigation, it's not just important, it's very important for our mind and how we can be able to allocate such lesions, and it can be very effective tools in training. And we can have different views for this. And as you can see, this case also have an accessory renal artery, and this is very important finding in the management of these patients, especially if you are dealing with transplant or donor or recipient transplantation, and if we are using also interventional techniques. The second group, group 6, they segment neck atlas, and those are and by the way, the names, the numbers of the groups are based on the Train the Trainers program. Khalid, Mujahid, Idris, and El Imam and Haitham, and they use and because the neck is the elephant in the room for all the medical graduates and undergraduates know that. So the neck has large number of vital structures, and it's one of the difficult anatomical areas. And the compact space, the important vascular bundles, carotid and jugular vessels make it really important area. So performing invasive neck procedures and writing detailed radiological reports are major challenges for the medical staff. We did not find, as the group mentioned, that they didn't find the 3D head and neck atlases available in the internet in the way that 3D Slicer would be able to present it. So they use the 3D, and they can use the 3D modeling to make it less complex and easy to digest. So in this, first of all, the neck area is really, as I mentioned, complex, and the components are varies from bone, muscle, fat, spaces, vessels, and a lot of structures. So they start by segmenting the skull, the neck, and the thoracic inlet. And after they complete this, they start with the other vital structures, the pharynx, the larynx, the hyoid bone, and then the cartilage, the thyroid cartilage, and then the thyroid gland itself. And this is very important when they say the thyroid is H-shaped, so the medical student and the anatomist can understand exactly what we mean by H-shaped. So, and then these are the major vessels. The arch of the aorta with the major 3 vessels giving the branching. And by the way, they have different colors. I just put it right now like this for the presentation purposes, but they give each segment its name: internal carotid, external carotid, the brachiocephalic. Every single one has its dedicated color. And those are the veins, and this is how it looks currently. And we expecting that they will continue to give the muscles and the rest of the spaces and the structures in this atlas. The Quinault liver atlas by group 6, and this is conducted by Nuruddin, Shiraz, Abdelmajid, and Osama, Omar, and Taqwa. And why Quinault classification? And pardon, I know that some people here are French speaking. I hope I said this correctly. So Quinault classification, because liver loops and segments can be divided into two anatomical classification systems: morphologic anatomy and functional anatomy. But the know-how mapping of the 8 segment is essential for surgical planning and for radiological reporting. This is a morphological anatomy, and this is the functional anatomy landmark, giving the left and giving the right side. And then the important structures are the vascular structures. These are the hepatic veins, followed by the portal veins, and then the gallbladder. Those are the landmarks, which then we can start to segment the different liver segments. So the Quinault give it in clockwise manner, starting by 1, then 2, 3, 4, 5, 6, 7, and 8 segments. And this is really very important, as I mentioned, in surgical mapping. One of the problems that they face, the surgeons, when they just go blindly into surgery, or they do not have a detailed information about the segments, their volumes, their locations, and their extensions. And this is our final looking 8 segments. So our future direction as a new born in this community, the trained candidates will continue their projects and add more atlases. And we will try to encourage the Sudanese software developers and computer scientists to join the community, which I really believe it's very essential and important. And we will communicate with high level, and currently we are communicating with them, authorities, so they can adopt this community and use it in their use it in the Sudanese universities as well, and supply and we will try to supply the open source repositories with segmentations. And I believe this can be conducted by master thesis and PhD thesis if they use the TCIA data or all the available image open sources, and then they can segment, they can use this information in their master and PhD, and then they can send back those segmentation to those repositories. This will give a real reward, back reward, and at the same time this can help the international community and the researchers into using this segmentation. As I noticed in the craniosyntoses project from one of the Spanish, I'm not able to remember this, the name of the PhD student, but they asked for 200 scan from US, from Children's Hospital, to do segmentation for the skull, so they can have a normal, then they can do another model for this craniosyntoses surgery. If we are able to provide from Africa these atlases, then we can contribute, and later on we can progress into the pathology and so on. I believe this is a good start for our community. And what we are expecting from NaMic community, collaboration in, I can't add more what the speakers, they speak a lot about exactly what we need, and funded research positions for the young research investigator. This will open new horizons for them, support the implementation of labs and infrastructure related to the medical technology and training. People needs online and hand-on courses, training and tools. And so these are the references, and many thanks for all the collaborators, for all the people. Many and special thanks to Naira. Naira, by the way, in my local language means the glowing lady, and she was really a glowing lady. She gave us a lot, and thank you very much for her support throughout the course, and her patience as well for all our questions. And to Leila Omar Adam, she was an IT supporter from Al Fashir, Darfur, and she supported. We have a small WhatsApp group for our people, and we are distributed all over the world. We are in Turkey, Sudan, Australia, here in US, and she was supporting all of us in any technical issues. And really, she did a great job. Thank you for her. And special thank for my local institute here, MGH and Harvard Medical School, Precision Imaging Metrics, because they gave me the chance, the time, and the space to participate in this week and to do all this support to my people in Sudan. As I say, first and last, to Juan, Ron, Steve, Mike, and Naira, Asma, I don't want to forget anyone, all the team, and the discourse forum of 3D Slicer. They really give a great support. They really give important information. Thank you very much. These are some images from our teams when they are doing, participating in this workshop, and hopefully some of them can meet you next year in Canary Island. Thank you very much, and I'm deeply sorry that it looks like I take a lot of time, more than expected. Appreciate your listening. Thank you.
Thank you very much, Tawa. Really very impressive talk. Thank you very much.
Thank you.
So our next speaker is Professor Moulay Idris from Al Azhar University in Mauritania. So Idris?
Juan Idris is having some problem with the internet connection, so maybe we can
Okay,
go with the next.
we can continue with the next speaker, and then he can try it later. So then we have Professor Alexandra Fernandez Rodriguez from Eduardo Mondlane University in Mozambique. Alexandra, please.
Thank you, sir. Let me share the screen. Thank you for this opportunity, and I would like to expose the Mozambique experience in the use of 3D Slicer based on the training program. We started the use of 3D Slicer by being trained in Las Palmas, Gran Canaria. I am a Mozambican medical doctor, and really I am the one who is leading the use of 3D Slicer in the country. We have this opportunity, and we are using 3D Slicer as it was developed to give to different levels of specialization in medicine an opportunity to use this platform to improve at low costs of possibilities for learning the usage of medical imaging informatics, imaging processing, and the three-dimensional visualization. We needed at Eduardo Mondlane University, where I am working in Mozambique, to change the traditional model which is used for teaching gross anatomy. And we also sought to incorporate active teaching methodologies to be or to get more involved the students in the process of knowledge construction. It means that when we saw the medical knowledge versus the new technology, we get a subject which is delivered in the most of the faculties in the world as a big challenge to the teachers and the students too, as a consequence of the permanent change that are required in the perspective of the technological development. Thus, the medical imaging technology become an indispensable tool in all the branches of the health area and the research, and also in other essential fields of the health professionals. The Mozambique training program started as a consequence of this training. With support of the Slicer community, I have participated since 2017, I've participated in the project weeks of the NaMic community, and I started implementing this program in Mozambique in 2018. It was decided to introduce the use of 3D slicer to the people who is teaching anatomy in the Faculty of Medicine in the University of Eduardo Mondlane, the students who is learning anatomy, the student who is assisting the anatomy subject as assistants, the students in the clinical cycle of the medical course, the residents from the different specialties in Central Hospital in Maputo, and specialists particularly related to the imagiology, surgery, and internal medicine. The activities started with the doctors who was teaching anatomy. 2 months after, we started in the same way with the students who was learning anatomy in first and second year of the medical course. However, it was not possible to have all the initial participants still involved in the training and less still using it as a learning strategy. It means that along the time we are losing the people involved, the students involved in the program. At the same time, we involved 6 students who were in the clinical cycle of the course and who were our assistants for teaching anatomy, particularly at the practical classes. We used the link which was available at this time. We didn't translate nothing because we are a Portuguese speaking country, but we didn't have the need to translate the documents from English to Portuguese because the students were able to use this documentation from the YouTube and the PDF also. At the beginning of the program, we expected to have computers at the medical school available to download the softwares and being used by the students. But we had technical problems. We still have these problems. And the students start using their own computers and their own cell phones, which means that the honors comes from the student to use the 3D slicer. The room which we supposed to use is this with 25 computers, but it's still not viable. Maybe at the middle of January, I will get the opportunity to have my students using this. We started using the data sample from the program. Locally, we obtained very, very few. We've got problems using and applying the images from Mozambique, but we have got support from the University of Las Palmas, Gran Canaria, particularly from Naira and Carlos. And actually, we have medical doctors teaching anatomy and some surgeons and physicians who are teaching in the clinical context, attending the training course on 3D slices offered by WellPG. It means that they are finished this week and they are around 10. We have, as you can see from the photos, different targets. The first one is one of our assistants he now finished the medical course and maybe will be integrated the teachers groups of anatomy at the medical school. The others are student, and the other one is one of our teachers of gross anatomy. I have got the opportunity to have more people involved. It is only a sample. And this is one example of segmentation which have been done by a student during the anatomy classes. We have a subject which we call clinical anatomy, and this includes the different parts of the body, the head, the neck, the trunk, and the limbs. And during each of these regions, the students needed to do a segmentation of the different organs of the regions. For example, in the limbs, they have done the femur segmentation as a part of the practical lessons. And one important thing which I have to stress is that the students finally discovered that they didn't know anatomy properly at the end of the lessons. And it was important for me because this is one of the aim, not to show that students don't know, but how to get the knowledge. And 3D Slicer is one of the way which I can confirm that it's important, and from that they can get the anatomical knowledge. It means the infrastructures of the medical knowledge. As a conclusion, I can say that we have to develop more training programs locally. We have to have more people trained as trainers. It was not possible until now to take all the people interested in attending the training. It means that more workshops are needed. And the good structure and organization of the materials available in YouTube and the free costs of the program, of the software, help to motivate people to use the 3D Slicer. It is necessary to have more trained trainers and get them involved as soon as possible as a technical professional provides. We need the informatics, we need the engineers, we need developers, not only the medical doctors or the health professions, but we have to integrate the technicians to get a program which can really be an opportunity to have more practical activities in the study of medicine. That's what I would like to share with you. This is the last picture to show that Africa is Africa, and Casa Africa in Las Palmas was one of the places where we could be involved in scientific and social programs. Thank you.
Thank you very much, Alexandra. So I think that Professor Idris is now online. So Idris, okay, so you have the floor, Idris.
Thank you very much. I think this time I will speak in French. Merci beaucoup. Je suis très content de participer dans cette rencontre qui, pour moi, est devenue presque une routine à cause des personnes que je connais parfaitement. Tout d'abord, je tiens au nom de l'équipe du laboratoire d'anatomie de la faculté de médecine de workshop je tiens au nom de cette équipe et à mon nom personnel de cette faculté de médecine de l'Université Al-Azhar de Nouakchott d'exprimer nos vifs remerciements au gouvernement des îles Canaries à travers, bien sûr, Nasara Cabrera. Et puis, je suis très content de trouver l'autre équipe du MAC BioID avec aussi l'Institut de technologie des îles Canaries. Je profite de cette occasion pour aussi exprimer tous mes remerciements, en particulier à Juan Ruiz Arzola, et aussi bien sûr à ne pas oublier nos remerciements à l'égard de l'équipe de Harvard Medical School qui est bien sûr le leader, professeur Ron Kukinis et son adjointe Tina Kapoor. Encore une fois, je ne vais pas trop dire parce que mon ami Yahya, je lui ai passé la communication, la présentation, il a presque tout dit, le maximum. Et c'est pour cela que je voudrais tout simplement exprimer nos remerciements concernant cette participation. Et comme certains parmi vous le savent, que les étudiants de la faculté de médecine, en particulier ceux de l'équipe d'anatomie, du laboratoire d'anatomie, ont pu avancer et ils ont pu faire, bien sûr, grâce à l'apport de leurs enseignants en Mauritanie, professeur Yahya et moi, avec l'ingénieur Septi, nous avons eu la chance de leur faire apprendre comment faire la segmentation et comment aussi pouvoir essayer de transformer des images d'ICOM en des images qui sont beaucoup plus claires sur le plan de la segmentation par la fameuse plateforme 3D Slicer. Nous avons participé pendant 3 années à des workshops et aussi tout dernièrement, il n'y a pas longtemps, à un webinaire organisé par le MAC BioID et surtout organisé par l'Institut de technologie des îles Canaries. Et ceci nous a permis de pouvoir transformer des images d'ICOM en des images beaucoup plus claires et en essayant de pouvoir acquérir un nouveau moyen de coopération qui n'est autre que le transfert de la technologie médicale pour un pays en voie de développement en Afrique comme le nôtre et nos voisins. La Mauritanie est le pays les plus proches aux îles de Canaries, juste 90 km qui nous séparent avec les îles Canaries. Et nous en sommes très fiers de ce bon voisinage. Et nous avons étudié pendant ces workshops et ces webinaires la plateforme 3D Slicer pendant la période où on était en trainer, c'est-à-dire que les enseignants ont été formés à la pharmacie et après ils sont venus dans leur pays pour pouvoir transmettre ce savoir pour les étudiants qui sont avec eux dans cette faculté de médecine. Ce qui était important, je ne vais pas trop tarder, c'est qu'il existe beaucoup. Notre objectif final, c'était essentiellement l'atlas d'anatomie. Il existe beaucoup d'atlas d'anatomie qui sont à imprimer et qui sont numériques. Mais aussi, le plus important, c'est de pouvoir créer des atlas d'anatomie qui sont sous forme des images cross-section. Et puis, l'open anatomy, c'est-à-dire un atlas d'anatomie ouvert, c'est une très bonne initiative. Ça permet aux étudiants de mieux pouvoir comprendre les rapports entre les différents organes et surtout de comprendre mieux sur le plan clinique certaines pathologies. Et ceci a permis à notre équipe de pouvoir, comme Yahya l'a présenté, de pouvoir segmenter le cerveau, l'abdomen, le foie, le pelvis et autres. Et je ne vais pas trop tarder là-dessus. Et il y a un projet qui a été, des projets qui ont été faits, qui ont développé, bien sûr, des atlas d'anatomie. Et en plus, l'objectif était surtout de faire une innovation dans le domaine de l'enseignement de l'anatomie dans notre faculté de médecine, de créer des modèles anatomiques en utilisant, bien sûr, la plateforme 3D Slicer. Et ceci concernait presque tout le corps humain. Et ceci a été exporté en essayant d'obtenir une segmentation pour un atlas d'anatomie ouvert. Et je ne tarde pas beaucoup, il y avait bien sûr les étudiants qui ont fait beaucoup de segmentation et quelques cas d'illustration sur le plan image que Yahya vous a déjà montré. Je ne tarde pas là-dessus. Et en plus, pour finir, encore une fois, je renouvelle mes remerciements pour nos confrères et nos collègues au niveau de la pharmacie, et je n'oublierai jamais surtout ceux qui nous ont visités en Mauritanie, en particulier Alex Golbi. Et bien sûr, c'est un grand plaisir pour moi de la revoir aujourd'hui. Et je n'oublie pas, bien sûr, Madame Sonia avec Mike Hall de l'équipe de Tina Kapoor et de l'équipe du professeur Ron Pikinis. Et je ne peux pas parler de ça sans pour autant essayer d'évoquer qu'aujourd'hui, je n'ai pas vu le professeur Gabor, qui, pour lui, actuellement, à cause de cette formation que nous avions, sur laquelle nous avons pu bénéficier à la pharmacie, nous sommes maintenant en train de pouvoir développer avec le Queen University, à travers le professeur Gabor, ce qu'on appelle un centre d'imagerie de guided thérapie, un centre d'IGT. Ce centre d'IGT, sans avoir bien sûr déjà acquis la formation dans le domaine de 3D Slicer, nous ne pourrions pas bâtir ce centre. Actuellement, ce centre, il est déjà presque acquis sur le plan structure, sur le plan bâtiment. Et comme Yahya l'a signalé avant moi, les moyens avec lesquels nous pouvons nous travailler, nous sommes là-dessus, et j'espère que ce centre verra le jour un beau jour bientôt, et que nous serions bien sûr ravis d'avoir la visite du professeur Alex Golbi pour essayer de nous éclairer encore davantage sur l'imagerie guided thérapie. Encore une fois, je ne peux que vous exprimer mes remerciements, et surtout en particulier à travers l'Institut de technologie des îles Canaries, et bien sûr, sans oublier le professeur Juan Arzola avec ses collaborateurs, en particulier Asma, et je vous remercie.
Thank you very much, Idris. And then we have the next presentation by Professor Babacar Diaw from Cheikh Anta Diop University in Senegal. So Babacar, the floor is yours.
Okay. J'essaie de partager mon écran. Vous l'avez? Non?
Non, pas encore, Babacar.
Not yet.
Quelqu'un doit fermer. Je suis bloqué. Partagez. C'est bon?
Oui, c'est bon, Babacar. Je pense que vous
C'est
pouvez
bon?
maintenant.
C'est bon maintenant?
Essayez de mettre les diapositives.
Oui, d'accord, c'est parfait.
Ok.
C'est bon?
Yeah.
Oui, c'est parfait. Vous pouvez mettre le plein écran, Babacar.
C'est ce que j'ai fait.
Merci beaucoup.
Bonsoir tout le monde. Je suis heureux aujourd'hui de participer à cette rencontre. Je vais commencer d'abord par saluer les officiels du gouvernement des îles Canaries, saluer mesdames et messieurs les panélistes, et également saluer tous ceux qui participent à cette rencontre, même pour les spectateurs. Je suis honoré de vous faire part aujourd'hui de l'expérience du Sénégal sur l'utilisation du 3D Slicer. Je ne serai pas long parce que l'expérience du Sénégal est connue déjà. Je pense que ce qui est nouveau, c'est que d'autres pays sont en train de faire des choses extraordinaires. J'ai vu tout de suite la présentation du docteur Takwa Idriss, je crois qu'au Darfour, de belles choses sont en train de se réaliser, et ça, c'est à l'honneur de l'équipe de Macbio Idi. Nous devons remercier tout le monde, et Juan et son équipe, et Ron et son équipe. L'expérience du Sénégal, je vais y aller tout rapidement, parce que nous avons eu aujourd'hui beaucoup d'exposés. Certains ont été longs. Je pense que le temps imparti a été dépassé parfois. Donc, je vais sauter certaines diapositives. Nous avons rejoint le projet MacBio ID et l'utilisation du 3D Slicer il y a cela 3 ans. Juan était passé à Dakar avec son équipe et l'ancien ambassadeur du Sénégal nous avait aidé à intégrer ce projet. Nous avons eu 3 semaines de formation où des scientifiques généreux ont pu nous offrir quand même pendant 3 semaines les outils de base pour utiliser le 3D Slicer et faire des projets, réaliser des projets, notamment dans le domaine de l'anatomie, ce qui a été le projet phare au Sénégal, le développement des atlas. Après cette formation, qu'est-ce que nous avons fait? Je pense que ce que nous avons fait a été connu par Juan et son équipe, par Ron et son équipe, et je profite de cette occasion pour dire au professeur Ron qu'aujourd'hui, je ne me connecte pas avec mon téléphone portable, donc il n'y aura pas de coupure. Je ne veux pas que Ron me tire les oreilles. Donc, à l'école militaire, nous avons développé une salle équipée de 40 ordinateurs pour les élèves. Et j'ai dit, si vous me voyez en tenue ce matin, c'est que j'étais à l'école militaire ce matin. On recevait les 40 nouveaux refus au dernier concours de l'école. On leur présentait le drapeau du Sénégal aujourd'hui. C'est pour ça que je suis en uniforme. Je reviens comme ça de l'école. Et ces élèves seront bientôt initiés au 3D Slicer. C'est devenu actuellement quelque chose qui fait partie de la vie courante à l'école. Et les résultats, comme je le dis toujours, on ne sait pas pourquoi, mais nous faisons de meilleurs résultats. Nos élèves sont vraiment enthousiastes à l'apprentissage de l'anatomie que tout le monde détestait, est devenu aujourd'hui un jeu pour les élèves de l'école. C'est des élèves de première année qui ont essayé de faire des atlas aussi bien pour de segmenter le poumon. Là, nous avons essayé de faire un premier atlas du pelvis en 3D et c'est pour dire au docteur Tahawa Idriss que c'est comme ça. Quand vous commencez la segmentation, et n'est pas tellement fine comme vous le voulez, mais progressivement, vous allez voir que les choses vont s'améliorer. Si vous voyez ce premier atlas, ce n'est pas joli du tout. Vous voyez les muscles, il y a des choses qui ne sont pas raffinées. Et quand nous avons repris plus tard, quelques années plus tard, nous avons fait de meilleures segmentations ici sur l'atlas du pelvis masculin. Là, sur l'atlas du pelvis féminin, vous voyez que ce pelvis avec un utérus rétroversé, qui est une variation anatomique quand même, que la segmentation est plus nette et cette vue inférieure du pelvis féminin, je vous assure que vos étudiants parviendront à faire des atlas similaires ou bien parviendront même à faire mieux s'ils prennent le temps de s'entraîner. Là, c'est l'atlas de l'abdomen que nous avons initié, mais que nous n'avons pas encore terminé faute de temps. Je pensais qu'entre le mois de juillet et maintenant, j'aurais pu le faire, mais j'étais pris dans un autre projet avec l'équipe du professeur Ron, du professeur Gabor et du professeur Juan. Et c'est ce qui a fait que j'avais arrêté la segmentation. Mais cette segmentation a beaucoup avancé depuis Boston et nous voyons que tout a été fait. Il ne nous reste qu'à insérer des muscles, le muscle dentelé postérieur de l'abdomen pour finaliser cet atlas qui est déjà utilisé par les élèves de l'école militaire. Sur le plan de la formation, je pense que l'équipe de Juan a beaucoup aidé le Sénégal. D'abord, en formant un pool de professeurs qui ont été à Las Palmas pendant 3 semaines. Nous avons essayé, nous, à notre tour, de former les enseignants de la faculté de médecine de Dakar, tous les départements de la faculté de médecine. Et récemment, c'est-à-dire au mois d'octobre 2020, ce qui a été intéressant, c'est les 2 sessions de formation qui ont permis de prendre en compte les 5 facultés de médecine du Sénégal. Dakar, Ziguinchor, Thiès, Bambey et Saint-Louis. Je pense que c'est une chose extraordinaire. Et au cours de cette formation, ce n'était pas seulement les médecins qui étaient intéressés. Il y avait beaucoup de computer scientists. Moi, je continue de recevoir des coups de fil de computer scientists qui sont dans les autres universités à l'intérieur du Sénégal qui me disent qu'ils sont vraiment intéressés pour travailler dans ce projet. Et je pense que c'est une excellente chose. Et je disais récemment que j'ai fait 19 ans comme enseignant à la faculté de médecine de Dakar. Je ne connaissais pas les enseignants de la faculté des sciences et techniques. Je ne connaissais pas les enseignants de l'école supérieure polytechnique. C'est grâce au 3D Slicer que nous nous sommes rapprochés, que nous travaillons actuellement la main dans la main. Il y a une dynamique de groupe à l'université chez Cheikh Anta Diop. Je ne peux, si je reste 24 heures sans appeler les enseignants de l'école supérieure polytechnique, ils m'appellent et je viens de les connaître il n'y a pas 6 mois. Et c'est grâce à ce projet qui est un projet innovant, qui est un projet qui rassemble, qui a permis en tout cas aux computer scientists de se retrouver avec les cliniciens. Nous l'utilisons également, le 3D Slicer, dans la communication avec nos malades. Je pense que les urologues l'utilisent déjà, utilisent déjà cette segmentation du modèle de McNeil de la prostate avec les 5 zones pour pouvoir discuter avec les malades, prendre des décisions avec le consentement libre et éclairé des patients. Et actuellement, ce sont nos collègues gynécologues qui m'ont approché pour développer également une segmentation du pelvis, une scanopelvimétrie, parce que je ne sais pas ce qui se passe dans les autres pays, mais au Sénégal, le gros problème quand vous sortez de Dakar, c'est ce qu'on appelle les mariages précoces. Et pour lutter, c'est un phénomène culturel. Vous voyez une fille de 13 ans, 14 ans qui est donnée en mariage, c'est difficile. Ce sont ces filles qui nous font beaucoup de complications lors des accouchements parce que ces filles ont des bassins immatures. Nous pensons qu'en faisant un modèle 3D, nous pourrons mieux expliquer, mieux convaincre en tout cas ces communautés en leur expliquant la difficulté qu'un fœtus aura pour qu'un accouchement se fasse par voie basse. Je pense que c'est quelque chose que nous avons commencé déjà avec les gynécologues et que d'ici quelques mois, nous pourrons en tout cas produire quelque chose dans ce sens. Donc, si nous voulons résumer, la communauté Slicer est devenue vraiment une large communauté au Sénégal qui regroupe plus de 5 universités, qui regroupe les computer scientists et les médecins et les étudiants sont vraiment enthousiastes à travailler dans ce projet qui est innovant. Qu'est-ce que nous avons planifié de faire en 2021? Le doyen de la faculté de médecine de Dakar, lui, a déjà programmé 3 sessions de formation pour les enseignants et nous avons décidé dans des différentes spécialités de produire plus d'atlas et je pense que le professeur Alessandra Golbi va pouvoir aider nos neurochirurgiens. Nous avons ici une professeure de neurochirurgie qui est vraiment intéressée par la neuronavigation. C'est le professeur Maguette Gaye. Je pense qu'elle gagnerait à se rapprocher du professeur Alessandra qui pourra l'aider à aller de l'avant et à recruter plus de neurochirurgiens dans ce domaine. L'intégration du 3D Slicer dans les premières années de la médecine va aider nos étudiants en première année, en deuxième année, et surtout, ultérieurement, va les aider à mieux interpréter les clichés de tomodensitométrie ou d'imagerie par résonance magnétique. Et nous voulons surtout développer la recherche translationnelle. Je pense qu'entre le mois de juillet et le 8 décembre, nous avons eu des échanges extraordinaires avec l'équipe du professeur Ron Kikinis, avec tous ceux qui ont travaillé autour de lui. Je pense que ça a pu éveiller chez nos computer scientists beaucoup de projets et nous pensons qu'avec l'appui de ces partenaires, nous pourrons réaliser ces projets dans le domaine de la recherche translationnelle. Donc, nous ne pouvons terminer sans remercier tous ces scientifiques, tous ces gens généreux, tous ces gens qui sont humbles, c'est de grands scientifiques, mais de par leur humilité, de par leur générosité, ils ont accepté d'appuyer les pays africains, d'appuyer et de nous montrer le chemin de la recherche avec l'utilisation des nouvelles technologies, de nous montrer la voie pour aider à mieux former dans le domaine médical et à améliorer la santé de nos populations. Je ne veux pas être long, ce sont ces quelques remarques que je voulais apporter à la spécificité sénégalaise et je vous remercie pour votre aimable attention. Merci beaucoup.
Thank you very much, Babacar. So we have reached the final part of our session today. Ron, would you like to give some final remarks?
Yeah, so when I'm sitting here watching, by the way, Babakar, you can stop sharing. Thanks. When I'm sitting here watching these presentations, I'm really, really happy because that was the original motivation with 3D Slicer, is to have a tool that enables research, and we have widened the scope to use it for teaching anatomy. And obviously, this is something that is an unmet need. We have also seen in the interaction with our partners that the same people that teach anatomy often are doing surgical activities as well. And they immediately take the notion, couldn't we use Slicer not just to teach students, but to plan surgeries? And so we see this going on now in several places. And I find this a very good and promising activity, in particular, because in my perception, surgery and interventions in general are not getting enough attention in the African context. And so in a certain way, it is a niche compared to malaria or HIV, but it's an important niche, and many people are affected by things that need to be treated surgically. One of the things that we will have to be careful about is that Slicer, of course, is not an approved medical device, so we can use it in a clinical context nor only as a research tool, not for clinical routine. But still, it's a low-cost way to get going on the technology, and it helps the surgeons understand the anatomy better before they go into surgery. Okay.
Thank you very much, Ron. So thank you very much to all the speakers for the wonderful presentations. I really look forward to this collaboration and to the future. I really do hope that we can meet in person soon next year, and that we can repeat an event like this presentially. So thanks again to everyone, to all the attendees, to all the speakers, and I'll give the floor to Nasara Cabrera, Director General for Africa in the Canary Islands government. So Nasara.
Merci beaucoup, Juan. Vous m'écoutez? C'est bien? D'accord. Et donc, merci beaucoup. Je dois dire que je ne viens pas du domaine de la médecine ou de l'ingénierie, mais j'ai beaucoup appris cette année de vos interventions. Ça a été un vrai plaisir. Dans la clôture de cet événement, je dois dire encore que je vous remercie beaucoup d'avoir participé avec nous. Et à toutes les institutions, le ministère de l'Éducation de la Mauritanie, l'ambassade de la Mauritanie en Espagne qui a été ici, présente aussi ici, à la Commission européenne, la Banque mondiale, l'Organisation mondiale de la santé en Mauritanie et bien sûr aux universités, le Harvard Medical School, pardon, l'Université du Soudan, de la Mauritanie, de la Mozambique et Sénégal, et aussi, bien sûr, l'Université de Las Palmas de Gran Canaria. C'est un honneur pour le gouvernement de îles Canaries de vous avoir accueillis dans cette journée qui met en évidence la nécessité de nous interconnecter encore plus, si possible, de mettre les connaissances et la technologie au service du développement et du bien commun. Et bon, j'espère vous voir dans un scénario post-Covid aux îles Canaries. Et pour finir, je profite de l'occasion pour vous souhaiter une très bonne année. Merci beaucoup à tous et à toutes. J'espère vous voir l'année prochaine. Au revoir, bonne journée, bon week-end. Au revoir.
Merci beaucoup.
Bye.